if you are in menopause or what we call postmenopause. Okay, almost all of you. Stand up if you have absolutely no idea what stage you're in, but something is definitely going on, and you came here to learn more. Okay. Stand up if you are supporting somebody going through menopause. Okay, we got the last remnants of people in there. Woo-hoo! And that includes my daughter and her college friends who are here, and they are here to learn more about menopause and supporting mom. Stand up if you're a provider looking to improve your menopause knowledge. There we go. And stand up if you're here because you wish this Menopausium happened 10 years ago. Is there anybody not standing? I think we got everybody. So we may be here for different reasons, but we all have our own experience. Oh, you guys can sit. I don't want to, it's like church, right? I'm going to stand all the time. We may be here for different reasons and have our own experiences, but today we're all part of the menopause community. Just tell you a little bit about Let's Talk Menopause for those of you who don't know. We are a nonprofit organization. We started about 5 years ago. Our mission is to change the conversation around menopause so women get the information they need and the health care that they deserve. We basically have many different programs. We have our menopause talks. They're free every month. All of them are on our website. We have over 40 of them with best-in-class experts on a variety of topics, from menopause hormone therapy to skin and nails to heart health to hot flashes to hormone therapy. Please visit our website, letstalkmenopause.org, and you can find all of them. We have our podcast hosted by the amazing Stacey London. And I believe, Ada, that we have a trailer because our next season is launching next week.
Hey friends, it's me, Stacey London, here to tell you that I'm back for another season with Hello Menopause. We're so excited to bring you more information, more conversation, more guidance on midlife, perimenopause, menopause, and women's health. This season, we dive into sexual health with Dr. Maria Sophocles, author of The Bedroom Gap. We talk about menopause and breast cancer with Dr. Corinne Men. Kim and Penn Holderness give us their advice about navigating perimenopause as a couple. We also get into skincare, fitness, identity as we age, and so much more. As always, everything is on the table in every episode, and you will get clear takeaways to help you navigate the menopause experience. The new season launches in May. Be sure to subscribe wherever you get your podcasts.
One quick programming note, Maria Sophocles, a leader on our medical advisory board, unfortunately could not be here today due to a family matter. And so in her place, the fabulous Corinne Men is going to do a double feature today. In your bags, there's also a QR code for an important sleep study. Please check it out, and there's a QR code there, and they're recruiting people for a sleep research study. A big thank you to our sponsors. We'll thank them later today. But first, I want to introduce Tamsen Fadal. One of the main reasons that menopause is finally getting the attention it deserves, the reason this conversation has gone from whispered to front page, is because of advocates like our host today. Most of you know her, but for anyone who's new to Tamsen Fadal, you're in for something special. Tams is an Emmy Award-winning journalist, author, documentary filmmaker, podcast host, menopause advocate, and a guide and mentor for millions of women navigating midlife. I don't know how you do it all. After more than 30 years as a news anchor on Channel 11, she turned her platform towards a mission that truly matters. She is the executive producer of the PBS documentary The M Factor and The M Factor 2, seen by more than 1 million women worldwide. And she's also the author of a must-read book, How to Menopause. She's also on the board of Let's Talk Menopause, and she's our ambassador. So Tamsen, we're honored to have you back up here today.
Well, it's so good to see everybody, Boston. I love that we're here today. Thank you for coming out this morning. So I want to bring up our first panel this morning. Is everyone ready? Is everyone awake? Okay. I have one cup of coffee. I'll be downing more as we go. Okay, so our first panel is Paging the Doctor, and this one is Perimenopause and Menopause 101. So we're going to cover a lot of the basics in this one, and then go into the stages of menopause, common symptoms, and treatment options for different individuals. So let's start out. Our first panelist, Dr. Corinne Menn, an OBGYN and menopause specialist with a focus on premature menopause and menopause after cancer, a leading advocate in the space. She serves on the Council of Advisors for the Young Survival Coalition and as medical advisor for menopause and cancer. Dr. Hadeen Jaffe is a psychiatrist, a clinical neuroscientist, and chair of the psychiatry department at Beth Israel Deaconess Medical Center here in Boston. She is also a professor at Harvard Medical School. Welcome. And Dr. Tara Iyer is a family physician, menopause and obesity medicine specialist, and medical director of the Menopause and Midlife Clinic at Brigham and Women's Hospital in Boston. Well, so Dr. Iyer, I think I'm going to start with you, if that's okay, and just kind of go over menopause, perimenopause, menopause, and postmenopause, and how you would define those.
Yeah, I mean, I think the terminology is important because it gets really confusing for women pretty consistently. So when we're thinking about this whole phase as a transition, we start with perimenopause. During this time, this is where we start to see changes in our hormones, which create changes in our menstrual cycles, as well as changes in symptoms, or the first appearance of symptoms. So this is essentially the phase, a very long and very complicated phase, leading up to your final menstrual period. Your final menstrual period, or how we really define, a classic definition of menopause is 12 months without a period, 12 consecutive months. And then everything after that is what we call the postmenopausal phases, or menopausal when we're thinking about it clinically. And I think one of the important things to think about, particularly in perimenopause, is that it's not just this sort of estrogen is slowly declining through this phase. It's this period where we have really erratic hormones that are really volatile. It looks very different in the beginning than it does towards the end. You might get more heavy periods, more frequent periods towards the beginning. Your hormones are all over the place, and then towards the end, they may be spacing out really incredibly. So I'm often talking to my patients, hey, this is a moving target. Mm-hmm. What works for you right now may not work for you in 6 months, may not work for you in a year. And so we kind of have to readjust along the way.
Yeah, I think that's so important to note that it's not just kind of one and done. Here's where you are today. Can you talk a little bit about, I think, some of the areas that are overlooked when we talk about surgical, when we talk about early menopause, and some of those categories that we're just starting to dive into?
Yeah, and those distinctions are so important, particularly because we may treat them separately and they may lead to different risk profiles. So when we think about what's sort of the average age that a person experiences natural menopause, we think about the time frame between about 45 to 55 years old, and later than that, we kind of term it late menopause. Then I would say between about 40 and 45, we consider that early menopause, and then earlier than 40, I would say premature menopause. And for both premature and early menopause, we know there are different and more considerate risk profiles, and this is where treatment becomes not only when we think about symptom burden and optimizing quality of life, but we need to really address treatment here to make sure that we are reducing chronic disease risk.
Dr. Menn, let's talk about the common symptoms of perimenopause. I feel like you could just take up the whole panel at this point with the symptoms of perimenopause, right?
Well, I mean, I think the most important point is the symptoms can start before you have a missed period. And that's been a barrier to care for a lot of women, because they'll go to their doctor and they'll complain of these very common perimenopausal symptoms: new onset of anxiety, new onset of sleep disturbances, maybe skin changes, maybe sexual changes. You might have hot flashes, but it can come and go. And so sometimes muscle aches and pains, et cetera, and there's a whole long list. But unless they're missing periods, they're often written off of like, oh, it can't possibly be hormonal because you're still periods.
And I think that's such a concern. I was talking to a young woman recently, and she said, I went to my doctor, and I said, I think, I've got a lot of these symptoms. She was early 40s, and the doctor said to her, listen, perimenopause is just trendy right now. And I went, oh my gosh, what? And she walked away really discouraged. But I think that keeping track of those symptoms and knowing where you are, if you're starting to see any of those symptoms you're talking about, can you safely most likely say that
Yeah,
menopause?
perimenopause is a clinical diagnosis, so really, really important for women to know that they shouldn't be kind of tricked into being told that it can't be peri because your hormones look normal, or told that hormone levels are how we are going to diagnose your peri. Because in any one blood draw, your FSH could be high, which could signify. Is this working right?
I don't know, it's going in and out,
Yeah.
I think, a little bit.
FSH could be really high, which could signify that you're going into menopause, and your estradiol could be low. 2 days later, they could be normalized.
Yeah.
Hormones are fluctuating so much.
Yeah. So what do you do about that? I mean, the blood test is not the answer.
It's a clinical diagnosis. It's a constellation of symptoms. It's her age. It's her medical history, and her menstrual history. And you put that all together, and it's actually not that hard. And it's okay. Not everything is perimenopause. There's things like iron deficiency anemia, which is a huge problem in a lot of women. There's thyroid disorders. There's other things. Not everything is perimenopause, but if it looks like a horse and it runs like a horse, it's probably a horse. And don't make us feel crazy for feeling that. Yeah.
Yeah, it's not just a trend. Dr. Iyer, let me go back to you for a minute. How long do the symptoms last? And then let's address, because you hit on it just at the end there, the long-term health implications that we should be aware of.
Yeah, I think the really important distinction there is a lot of people and a lot of my patients when we were in clinic think about it sort of like, I just need to get through this, right?
Yeah.
Like, when is this going to be over? And in reality, they really mean perimenopause or just their symptoms, whereas menopause itself is not something you really get through. It's a state that you're in, longitudinally pretty much until your last breath, right? But the symptoms really vary. Some of those symptoms tend to be starting in perimenopause, lasting through the menopause transition, but then peak and can reduce, like for example, hot flashes and night sweats, right? On average, for most people, those might occur for about 7 years total, but that really varies from person to person based on a variety of different risk factors and characteristics. And very unfortunately, sometimes I have patients who never get rid of them, right? I have patients who are 80 on therapy, right? And then there are some other symptoms, but then also, on the other side of the coin, I certainly have patients a couple years after menopause, no longer with hot flashes and night sweats. Then there are other symptoms like vaginal dryness, for example. If you don't treat that, it just gets worse and worse and worse from the last time that you have a period. So it really does vary per symptom. And then when we think about the menopause transition and the loss of hormones and how those profoundly impact the body, in particular estrogen, the other thing is we have to kind of think about this as a whole body change, right? There are symptoms that affect us and are really burdensome, but then there's other things going on underneath the surface that we don't feel. When we think about bone health, for example, or cardiovascular risk, these are the sort of years surrounding the menopause transition. These are accelerated periods of risk for both cardiovascular health, due to changes in cholesterol, in terms of metabolic factors, in terms of vascular health. Same with changes in bone health, accelerated bone loss we see around our final menstrual period as well. So there's a lot we're looking at towards the future.
Okay, Dr. Jaffe, I want to talk about how these symptoms differ according to race, ethnicity, and socioeconomic status.
We know from a lot of studies that we've been doing since the 90s, one particularly called SWAN, Study of Women's Health Across the Nation. We've been following about 3,000, very exciting, it is amazing. 3,000 women, multiracial, multi-ethnic, 7 sites. We've been following people since 1994. And what we know is that the menopause experience, the menopause symptom profile, differs by race. A little less known about ethnicity differences, but we do know that some people have worse menopause, longer symptom, and more burdensome symptom, and that is particularly African American women. We don't know why, and it's not explained by other things that we've looked into, and we don't know if it's something biological or something in the lived experience, but we do know that that's a vulnerable population. And I also could say that some populations have less burdensome symptoms in terms of specifically hot flashes, and that is our Chinese American and Japanese American population that we've studied. So Hispanic and African American women tend to have more symptoms, hot flashes in particular, but also other things like sleep problems, whereas Asian women are, for some reason, not as symptomatic with those symptoms, but burdensome other burdens, right? It's like a constellation that varies a little bit between races a bit.
So let's talk about whether or not somebody knows they're in perimenopause. And Dr. Men, you mentioned this. Dr. Iyer, I know patients come in and say, like, it's just, give me a test. Is there one test I can take so I know yes or no? That's what I want to know. What do you say to those people?
Yeah, so we usually think about it, and this is a really reasonable question, I want to say, for patients.
Sure.
And there's so many fields of medicine where we get blood work and that gives us a diagnosis, or we get an imaging scan and that gives us a diagnosis. And I think it's really important to acknowledge that historically and presently, women keep getting dismissed in their offices. So looking for something objective where they can say, hey, it's not just that you're believing me, look at this thing. I swear these things are happening to me. I understand why so many people want the test, right? But I think that also, really alludes to difficulties in our medical care system where we just have to be listening to women as a provider. As Dr. Men mentioned, the absolute best way to diagnose somebody in the menopause transition is going to be by clinical history. We talk about what are your menstrual cycles, what symptoms are you experiencing, how cyclic are those symptoms, how severe are they, many different things. And how I usually explain the testing is, well, A, we may need some blood work, as Dr. Men mentioned, to rule out other things. Not everything is perimenopause. But B, outside of that, really what matters is your story. And the thing that can be discouraging as well is that sometimes the labs are misleading, right? They are a snapshot in time. What matters at this moment, this hour, this second that you get the blood work, not what's tomorrow, not what's a week from now. So they can look quote unquote normal, and then you can be dismissed in the office, right? Those labs were normal, when we know that there's actually something going on. And then lastly, I would say there are times where we do utilize those labs, particularly if we can't rely on the history because, for example, say you had your uterus removed and we can't track any menstrual cycles. Well, then we need something to be able to tell us a little bit more, something objective. And while those labs are imperfect, they can be helpful data points at that point.
Yeah, I think it's so important for women to know that, just because I hear that word normal so many times. Like, they said my labs were normal, and I think I had the same answer several times. I wound up going back through old paperwork before patient portals, I guess. But and I found like my results of a doctor's visit, and it said patient complains of moodiness and weight gain, labs normal. And I went, oh my gosh, that must have been perimenopause. But that's kind of how it was addressed, and I'd never heard the word before. So I think that's what's still going on in so many places. Dr. Jaffe, I want to spend a little bit of time zooming into mental health during menopause, because I know it's a really big area and sometimes gets overlooked. Why is the menopause transition a period of vulnerability, in particular when it comes to mood and it comes to cognition and it comes to sleep issues?
So this is, I don't know how much time we have for this one.
As much time as you need for us to get some answers.
A lot of people have questions about this, and I want to say, I've been working in this field since the mid-1990s, and at that time, the understanding was that it was women grieving about loss of reproductive potential. Okay, we have come a long way.
Crazy.
Yeah, we have come a long way.
Being happy about it, right? Like,
there's the happy part.
Exactly.
There's the happy relief part. But I don't mean to minimize the psychological experience, which is it's right there in your face.
Yeah.
It's like, I'm aging. What does aging mean? It may not have to do with reproductive potential, but it might have to do with a sense of what you visualize about aging experience, about illness, about health, about your sense of self and the world and your family and your roles and work and so forth. There is so much about that. Everybody handles it differently. Everybody experiences it differently. So that is really important. Some people, if they get to it early, they're like shocked, right? If somebody's 40 or 35 or they don't have like friends or others. Somebody, having seen some 58-year-olds who are still cycling, they're like thrilled when they're finally there. And obviously, the huge amount of variation. But what I want to say is that we've advanced our understanding and I think create a lot of validation for women that what people experience is in the brain. I always say to people, yes, it's in your head, it's in your brain. Like there is brain biology of what's going on that is driving this mood, sleep, cognitive change. Is that the only explanation? Is that, no. You know, obviously a lot of life happens over, you know, perimenopause on average 4 years. A lot of life happens. But for some people, and also fortunately most people do just fine in terms of mood. I think that's, you know, we clinicians tend to see people who have problems, but there are many, many people who go through this, and we don't want to be fear-mongering. I think, you know, you think about pregnancy and postpartum, we don't want to say, like, everybody's going to get postpartum depression. That is not true. The same thing, it's a minority of people who get perimenopause-related depression. And you heard Dr. Iyer say, you know, some of the symptoms are more circumscribed around the perimenopause and early post, and some kind of accumulate and get worse into the post. And mood, sleep, and cognition are definitely what those symptoms, the brain symptoms that are kind of circumscribed around this transition. And they are related, you know, again, varies a little by symptoms, but related to these changes in hormones in the body, which we think are also affecting the brain. And it can be the up and down of the estrogen. It can be the fact that progesterone is going down. It can be also the fact, like for cognition and mood, that people are sleeping poorly. So it's not only the hormones, but it's the fact that the sleep is poor, and then there are these downstream effects on how people function and feel the next day. So I'm happy to kind of come back into each individual symptom, but just generally, I really want people to know, you know, this biological phase, for some people, they get worse migraines. And then as their hormones settle down, the migraines subside. And the same is true for these, you know, mood, sleep, cognition, that we want to help support people through this vulnerable time and know that we want to encourage them to know that they will be fine. They will be supported if they're in the right care and have the right awareness and monitoring, and then things can really become stronger and more stable for them as their hormones settle down.
Can we talk about cognitive behavioral therapy? Because I know that is talked about quite often, especially in this transition.
Sure. So cognitive behavioral therapy, which is often CBT. So CBT is a strategy of interacting with usually a therapist who's trained in it and somebody who's seeking to get symptom relief. So it's very much related to symptom relief for often, you know, mood symptoms. So CBT can be for anxiety, for depression. There's also now a CBT for menopause symptoms. And there's also something called CBTI, the I for insomnia. So that's a strategy for insomnia symptoms. And the bottom line is that it's a prescribed kind of course of treatment. It can vary from, you know, 8, 10, 12 to 20 sessions. And if you're doing CBT, you should be getting homework. You should be doing workbooks. It's not, it's reflective, so you can self-evaluate what's going on. Why did I go down this path of thinking this way, feeling this way? And I think of it like peeling an onion. Like you really dig into the layers, like automatic assumptions. You assume when somebody doesn't say hi to you that nobody likes you, right? So we all have these automatic assumptions. And this CBT can have you like really parse that and say, what are the other possibilities? Maybe they didn't hear you. Maybe they were distracted or busy. Maybe they're in crisis for something. Maybe you might could have, you know, paused and said, you know, I just wanted to introduce myself, you know, and so it helps you stop and think about different alternate explanations. This is CBT for like anxiety, depression. It helps you think about different behavioral choices. Like I was saying, you know, make a different decision, make a different action. and also to not evaluate yourself in the same negative lens. And of course, CBTI, which is insomnia focus, is going to be more focused on, sleep hours, sleep awakenings, sleep behaviors, like what did you do to get back to sleep, or what kept you from going back to sleep, because people, doom scroll, all these things. So it's very like, stop doing certain things that lead down the wrong path for optimizing your sleep health.
And then just one more thing to talk about. Is this working? One more thing to talk about. Medications prescribed during this time, especially if you're looking at any type of mental health issues or concerns during menopause. I know a lot of women have said, and myself included, I went to the doctor and before I knew it was menopause, and I was given a Lexapro. In reality, I went back to another doctor and then found out I was in menopause. So can we talk a little bit about SSRIs and other prescribed medicine?
Yeah, so you heard Dr. Men say that, sometimes people are dismissed, that it's not perimenopause or hormone related in some way. Sometimes the reverse can happen, where people say, well, of course this is happening to you, it's perimenopause. So it can go both ways. We have to be self-aware and evaluate and think about it. So there are people, for instance, who have, multiple recurrent of episodes of depression. When I talk about depression, I mean clinical depression that's persistent, pervasive, affecting their ability to function. And they may have multiple episodes. Once somebody has one episode, 50% chance of a second. Once you have a second, 75% chance of a third. Once there are three, 90% of more. So if somebody, by the time they reach midlife, has had multiple episodes and maybe came off of an antidepressant because they just didn't want to be on them, they didn't like some side effect, it might be that it's a vulnerable time and the antidepressant is the right thing for them. So for some people, in the same way we think about postpartum depression, somebody might have come off of antidepressant in pregnancy, they have a history of depression. The right thing is to treat the depression, of course, support psychotherapy and oftentimes antidepressant. So sometimes the answer very much is serotonergic treatments, because they are the most robust treatments for medication treatments for mood. Of course, we have many other medications for depression that these SSRIs, SNRIs are first line. However, when the problem is more like a milder mood condition and it fluctuates across with the hot flashes and all the irregular cycles, comes and goes, it doesn't end up being as severe, as intense, and there are a lot of hot flashes, that's where hormone therapy, usually, of course, primarily estrogen, is hugely effective for that in the context of hot flashes. It is not effective for a mood condition in the postmenopause when there are no hot flashes. So we're talking now about perimenopausal, in this hormone fluctuation, milder condition, and so, and there are other strategies too, but that's sort of how do we think about when to go down the path of hormones, milder, really tracking with the hot flashes, versus when to go with an SSRI, SNRI, more severe, more pervasive, persistent, interfering with function.
Thank you for zooming into that. Dr. Mann, let's talk about the available non-hormonal options that are out there and what you recommend to patients.
Yes, and we're not diving into non-hormonals because that's the first line for most patients. We're doing that now because you're going to hear all about MHT and use of hormonals. So it is important for women to know that if they cannot use hormone therapy or they choose not to use, because everyone has a choice here. It's not one size fits all. It's good that we now have better studied, newer, non-hormonal specific FDA-approved medications that specifically treat vasomotor symptoms. Hot flashes, night sweats, and the resulting insomnia. And I remind women that a lot of the downstream effects, if you're not sleeping at night and you're being woken up by hot flashes and during the day, that's going to impact your mood, your ability, your fatigue, et cetera. So there are 2 new medications in the last couple of years. The brand names Veozza fezolinetant, and lincunate or elezinitant. And these are working on receptors in the hypothalamus. And when estrogen gets low, these neurons in your brain fire off erratically, and that's where your thermoregulatory system is, controlling the hot flashes and the night sweats. And they're quite effective. I have a lot of use using them in patients because I take care of a lot of breast cancer survivors who may not be able to use systemic hormone therapy. And what I tell patients is I like these as first line because they're specifically designed for the hot flashes and night sweats. Traditionally, before we had these medications, we used a lot of off-label medications. There's one that's FDA approved called paroxetine. It's a lower dose of a common antidepressant, and then off-label use of other SSRIs, so antidepressants, SNRIs, like venlafaxine, brand name Effexor, as well as other medications that are used off-label, like gabapentin, oxybutynin. And there's side effect profiles. So, and sometimes there's positive things that you can get from some of these medications. So you look at what the patient's symptoms are and what their needs are. So it's good to know that you have those non-hormonal choices. They're not going to protect you from bone loss. They're not going to protect other things that estrogen's helpful for, but in the right patient, it's important that we have them.
And we're going to go into, we'll share. We're going to go in again to menopausal hormone therapy in depth and do a deep dive. Are there certain things to avoid, generally things to avoid when we're talking about non-hormonal options?
Well, general things to avoid in life, or no, I'm only kidding. At this time of life, toxic people is one. No, it's true. I mean, I think, no, because treating menopausal symptoms is sometimes it's a time to pause and see, like, how can I change things in my lifestyle, my interactions, what I'm doing, and avoid that. Avoiding, in terms of you're out there, I know what you meant though, you're out there, and there's a lot of things being sold to women and a lot of promises that these things are going to help you. The Menopause Society in 2023, and anybody can look this up, there's a non-hormonal position statement. It's quite well done, and it reviews the available clinical evidence of the prescription medications as well as the over-counter supplements. And unfortunately, we don't have robust data in some of these supplements. Not to say that some of them can't work. We can't just write off things because no big drug company put a lot of money into them, but just we have to be cautious, right? So my recommendation is if you're going to try a non-hormonal supplement that is purported to help you with hot flashes, night sweats, and insomnia, look for something that's single ingredient, proprietary blends. You have no idea what that mixture is and what the different doses are. Just see where it's coming from, see if it's got like third-party testing. I'm not going to name brands and stuff. There are some that might be beneficial. And again, in the non-hormonal position statement, they'll list some of them. And then some of the non-hormonal things you can do that also help is, yes, eating a healthy diet, avoiding alcohol is one thing you can avoid to avoid hot flashes, night sweats, and insomnia. And so sometimes those small changes go a long way.
How big do you think the lifestyle changes are in all this? Because we talk about them a lot in every area, whether we're talking about mental health, whether we're talking about menopause, perimenopause. How important are they at this point?
I mean, I think they're critical. My little saying these days is you can't outpatch a really crappy lifestyle. And I say this because I have a lot of patients who are young breast cancer survivors who are dealing with, years of prolonged estrogen deprivation, or they may have other medical complications and they're older, whatever the case may be, and maybe they can't use hormone therapy and they feel like they're doomed, that they're going to really be in trouble on the long term if they don't take HRT. And I remind them that, like, for chronic disease risk prevention, the best thing you can do is exercise, eat a nutritious diet, avoid alcohol, develop good relations with community and friends and family and relationships. Those things are key. Now listen, if you can take hormone therapy, yeah, you're going to hear about it. It's going to help your bones. And if you start it early, there's a lot of data that says it, maybe cardioprotective. Like, we can get into all of that. So it's like an added benefit, but the lifestyle's the pillar. And so again, a time to pause and reassess what you're doing. And don't believe the hype. You don't have to do a crazy diet or a crazy exercise regime. You just need to make small, actionable changes, and it does make a huge difference.
Do you feel like women are coming to you more informed these days and reading more, paying attention more? They know what might be happening with them?
Yes, this is the positive side of social media and where we're at these days. A well-informed patient makes all of our jobs easier, even in a patient who has maybe some things that they ask about that maybe we don't agree. It's okay, because it opens up, it's an opportunity to learn. And because I see a lot of very vulnerable patients, BRCA previvors, women with premature surgical menopause, these women are often dismissed and ignored. And so, those women standing up and being informed are really important, because the implications, if they get denied menopause care, are huge. So I think it's very empowering.
Yeah, there's no question about that at all. Dr. Iyer, what about you? Are you seeing a lot of people advocate for themselves now, speaking a little bit differently, speaking up, feeling like they're coming in educated about what's going on?
Absolutely. And I would say that, again, I think that's one of the positive sides of social media. I can't tell you how many patients I have that come in and are talking about their algorithm and how they're like, I cannot see one thing that is not perimenopause or menopause on my algorithm. It's the only thing on there. Or this supplement or that supplement or whatever is being either sold to them, but also really, really great content and information that they're learning. So it's a little bit of a double-edged sword, right? We have to be able to sift through, what is maybe potentially inaccurate or misinformation versus what is actually really great information that you can use and bring to your healthcare provider and advocate for yourself with, which is a hard job to put on the patient.
I think so
to be
too.
honest. Which is also why I think medicine needs to shift in that way. We need to be seeing and absorbing this content too, so that we can make it easier for our patients to distinguish between what is correct, what's not correct, and sort of bridge the gap for them.
Preparing for a first appointment, is there some advice that you have for women that are going in the first time and know they have to bring a list of their medicines, bring a list of their family history, make sure they know how to advocate for themselves, and bring your symptoms? Can you give us a list to prepare for that first appointment?
Yeah, I think you hit most of them, to be honest. And I would say I think everybody here should feel really proud, because I think the first step is educating yourself about what even to look out for. Particularly if we're earlier on in this transition, what am I looking for that I should put, hey, this is a red flag I need to talk to my physician about. So there is education, I think, just to know what should I look for. And then apart from that, it actually can be really helpful to track your cycles and your symptoms and bring those to your provider, particularly because this is sort of a minefield that we're sifting through, right? There's so much going on, and as we talked about, not everything is perimenopause. You gotta think, for a lot of my patients, this is the toughest time in their life. They're like, I've got a teen, she's going through her hormonal issues too, now it's the both of us. I'm at the peak of my career. I've got, the most important presentations of my life. I've got aging parents I'm taking care of. We've got a whole lot going on, and it's probably the least amount of time we're spending on ourselves. And so some things, it's really helpful to know, wait, are these symptoms that are cyclic and are occurring right around your menstrual cycle or right before your menstrual cycle? Are these things every single day that get worse around a stressful event? We can really help parse through exactly what's going on when we have more detail like that.
Are telehealth options making things easier for areas that might not have menopause specialists? Are you seeing that in different parts of the country?
Yeah, we are absolutely seeing that. I will say that as well, I would consider sort of a double-edged sword.
Yeah.
I think there are certain platforms and avenues where you have amazing care. And listen, we're in sort of a care desert when it comes to menopause, even, I would say, nationally. Even here in Boston, right? We have one of the most amazing medical systems and communities that exists on the planet. Yet, speaking as somebody who runs a menopause clinic in Boston, our wait list is so extensive. I mean, the demand is incredibly outweighing the supply, right? And we have to constantly train people to try to increase And that comes with its whole host of logistic issues. So that's Boston, let alone if we're thinking about rural areas of the country, in the Midwest, for example, there's no one, right? And so I think we're providing access in a way that is really crucial and critical, but at the same time, it's really important to understand that we need to be searching out expertise that is validated, people who have experience and people who have credentials.
Yeah, it's interesting. When we did the films, the number one question every time we would finish one of the documentary screenings, and we had them all over the country, is where do I go to get help? Like, what do I do? Like, I've got all this information, but now I don't know who to see or where to go. And we realized that was like kind of the number one question over and over, to provide Boston-specific options. Can you give us some of those? I know you said you're running one of the big clinics.
We have a great clinic over at Brigham, and there's also one at Mass General Hospital, and I know a few of our other institutions in the area as well do have clinics where they are seeing patients. I would say, though, more broadly, what I think is important is to search. We have some great access websites as well, like the Menopause Society, for example. You can put in your zip code and find a Menopause Society certified practitioner. When we say, we really want to vet somebody who has experience, this is somebody who has taken the time to learn something extra about this, take a test, attend a course, right, and has put this as a staple that, hey, this is a stamp I care about providing good care in this space.
Yeah, I think it's really important to note that, because there's so much going on out there, so much online, so much that can be confusing to people, and especially with all of our algorithms looking the same way. Because I always think it's just mine, and then it's everybody I talk to now that isn't even maybe just because they're around me and I say the word menopause so many times in a given day, I don't know. Dr. Javi, how are you seeing patients come in there? Because you're dealing with patients at all different issues that they're coming in, but are a lot of them feeling more informed and concerned about sleep, about mental health issues?
Yes, so firstly, for those of you who are in Boston, we also have clinical services at Beth Israel Deaconess Medical Center for menopause clinic. We also have one at the Harvard Cancer Center, which is Dana-Farber, where we see people. And so I will say we are fortunate that we have menopause practitioners in all of these contexts. It's still not enough of us. It's still, and actually the best thing is the person who knows you, your primary care doctor, your gynecologist. That's the best thing, because they've seen you through other parts of your life course, and they know you and your values. So, this is what, Dr. Iyer was saying, is there's the risk benefit to going to telehealth is even more removed. So the more somebody knows you, the better they can help. And, I have to say there are a lot of male and female providers who really want to stand up and be available. Sometimes people feel like, oh, they won't understand, they won't know, especially men. I think most of them mean incredibly well and want to be a resource. And so if you don't feel supported, or if you think you need a consult, that's a different story. But I would say always try with your primary provider. I will say, and just to comment on the preparedness, I will say I love millennials. Like, thank you, millennials, thank you, really. Like, millennials have said, wait a second, like, I've had my health and my awareness and my body cared for in all these ways, and like, why is there silence here? Like, why is there silence? And so that is pushing, I think, everybody in the medical system, in our society, in our community, our families, to talk about this. And so that preparedness, which is informed, makes a difference. And for me, the best thing is when people track. They track, and they say, if I get too much data, I can't integrate it, right? Mm-hmm. So it has to be like, like if you had migraines or irregular periods or painful periods, there'd be some sense of like over the last 3 months on this, this many days, some kind of like integration of how burdensome something is. Mm-hmm. And I think that's true with mood, cognition, sleep, because we all remember the worst days. We don't remember the best days. Yeah. And so there's like this magnetic overemphasis sometimes on the bad days, and it's not to minimize the how bothersome it. I mean, if you have a really bad day and it happens more frequently, we have to integrate that. So some sense of frequency and intensity of these symptoms with some kind of prospective daily tracking. We're never good about retrospectively trying to remind ourselves about that.
Yeah, that's good advice. Dr. Mann, what were you going to say?
I agree that there's a lot of primary care doctors and general GYNs, and even maybe if a couple years ago they weren't willing to have a conversation with you about menopausal hormone therapy or treating your GSM or whatever it is, they might be now. And so, you know, a couple of simple strategies: call the office, ask the office manager, hey, does Dr. XYZ, do they see menopause? Are they prescribing hormone therapy? Or when you make your appointment, say, I'm making this appointment to talk about menopause, and I'm just giving you a heads up. So they know. And if they're not interested, or they're like, no, I don't do this, send her elsewhere, they'll know. Send a little portal message. Please don't send a book. I do have patients who feel very proud, and they send me like 3 pages of like all these things. And actually, that's not helpful because doctors, you know, don't have a lot of time and their eyes will glaze over. But if you give us a very targeted bullet point, here are my top 3 things. This is what I'm concerned about. Here's a very quick, like a little quick synopsis of my history. It can be really effective because within a minute I could read that and I get that clinical picture before she even steps in the door. So help them out, and it will. And don't expect it to be done at your annual visit, 10-minute visit. You gotta pack a lot in. Breast exam, maybe a pap smear, other things. So sometimes book a separate problem-focused visit at the same time when you book your annual.
That's what I was going to ask you about. Do you just say, I want a separate visit that I want to specifically talk about where I am?
I think so. But listen, I get it. People have copays, high deductibles. They don't have a lot of time. The next visit is maybe 6 months in advance. So sometimes if you could just give them at least the heads up, maybe they can at least get you started on something, and then schedule you for a follow-up.
If you have a doctor that is like, yeah, I don't talk about this, whatever it is, 2 things, I guess. If you have a doctor that doesn't talk about how to move to another one, and are there other disciplines that are taking this on now, so it's not just falling on all OBGYNs?
Yeah, it's your primary care doctor. It's nurse practitioners are doing a great job. There's many women's health nurse practitioners who are really focusing on this, and I think they're stepping up to meet the needs that a lot of, frankly, OBGYNs have like dropped the ball on. I'm just being honest. I'm an OBGYN myself, and it is true. And so we need everybody. Certainly mental health professionals, I often find, might be the very first person to really understand, like, hey, I think that you need to talk to, they're part of like screening the patients and referring them on. So yeah, it's all hands on deck, and menopause is not owned by the OBGYNs. It's owned, it's primary care, frankly.
Yeah.
And we all need to be doing it.
Yeah, thank you so much. All right, we are going to get started on Q&A. I just want to remind everybody, so we have a microphone here that if you have a question to step up to, and keep them general and for this panel, if you could, just because they really can't give you, individualized advice today. If you want to submit a question online, we're looking for those too. So I think we're going to start with some of the online ones.
Yes.
Is that right?
Yes.
And then if you have a question, pop up to the mic and don't be shy because they have lots of brilliant answers.
I'll ask 2 quick ones from online, and then we'll move to the room. So I had surgical menopause and my symptoms were more intense. Is that normal?
Extremely normal. Because it's abrupt, it happens immediately, and even a postmenopausal ovary produces actually low levels of estrogen, and testosterone is cut in half when you have surgical menopause. So, and there's no transition time. So yes, very normal, hence why you should demand a plan preoperatively.
Okay. And the next panel is on hormone therapy, so I will actually ask if you do have something on hormone therapy. It's a big topic. We have a whole hour dedicated, so not too specific there. But there is hype about peptides and creatine supplements. Can you talk a little bit about those, speaking of algorithms?
Any of you, or you guys can multiple take it? Yeah.
Yeah, so I think it kind of goes back to what we were talking about overall with supplements. We have to be a little bit careful because we don't have robust studies on them. When we think about peptides, we're thinking about them, I think they're all over social media very generally, right? GLP-1 medications that are FDA approved are technically peptides. So those are peptides that have a lot of evidence and data and research behind them. And then there's a bunch of things from compounding pharmacies that no one's ever heard of that someone is coming to you from that we can't say one thing about, right? And so we have to be very careful and cautious when we don't have really robust research. Again, like Dr. Men said, we can't say they don't work, but we can't say they do. We can't say they're worth your time and money. We can't say they're safe. And so those are really important things to consider.
Yeah, I'm sure everybody on this panel agrees that the peptides that are not FDA approved, that have like weird names like N3256, like none of us recommend them. There's like literally no human data. There's like maybe rat data, but that's it.
Sounds like a Star Wars figure.
It's crazy, but supposedly very hot right now in like Facebook moms groups. So beware of the peptides, moms.
All right, there we go.
In LA, we
I
have
know.
a text chain where we ask about difficult menopause questions, things like that. Every 2 days, she's like, "Have you ever heard of this peptide? Have you heard of this one?" You're just coming in with it.
I get asked a lot, like what I'm on or what I'm doing, and I said I don't do peptides, and they said, "What? You don't do peptides?" And I said, "No, should I?" And so I got so panicky, and now my algorithm's got that too. Okay, let's go to the next question.
My question is actually on insomnia. So I do appreciate the treatments that exist for CBT, CBTI, but those mainly to me appear to be influencing your behavior or your thoughts. Whereas when I think of a condition like obesity, it is treated as a metabolic disorder. So now we have GLP-1s that work on, the insides, and basically somebody is able to lose weight. How about approaching insomnia as a metabolic disorder so that even if you're doing all the things that your CBT specialist is working with and you're still experiencing insomnia, then you don't feel guilty? It's not like, it's not your fault. It's just something inside you that's broken. Is there any kind of research that's going into that direction?
Yeah, thank you, and I agree entirely, that for many conditions, there are lifestyle behavioral strategies that are really important. Obviously, like weight loss, before we had GLP-1s, and even now in the post-GLP-1 access, weight loss and lifestyle and exercise are important. So it's not either or, it's often both. But the other point you're making is there is a biology to insomnia. When we talk about insomnia, we're not talking about, I had a little sleep problem last night. We're talking about a condition, it's a medical condition, lasts at least several months, problems falling asleep, staying asleep, problems with daytime functioning and relation. So it is described clinically. You see there's information in your bag about a research study. Dr. Burdish is leading nationally on that. So there are treatments, there's biology. We don't want to be moralizing. So I think you're getting at this moralizing question. Because it is biology, there's brain chemistry, that one of which is called orexin, a sort of brain activating substance that we can counteract to help people relax in terms of their alertness, hyperarousal kind of state in order to help people sleep. So there are medications that block this orexin, several that are approved. There are, of course, the quote-unquote Z drugs that can be used. There are other medications. There are a big range of medications. Some of them we try and use short-term. Some of them we try and use, we also use longer-term. Some of them we use like every night, but then there's like a rescue strategy. And with hormone therapy, just to say, the evidence is not that strong that it treats insomnia. Does it treat mild sleep problems related to hot flashes? Yes. Does it treat significant insomnia? The evidence is not there. So if people are put on hormone therapy and their sleep is not smoothing out and getting fully controlled, there are other options that should be pursued. And you need to work with somebody, kind of work through it, to try things, evaluate, see how you do.
Women deserve a solution for every single symptom that they're experiencing. But if you could talk more about what you think the more bothersome or like life impacting symptoms you hear your patients talk about.
I think for me and my patients, and what I experienced myself personally, was the sleep disruption, and frankly, a lot of the mental health aspects of a particularly abrupt or prolonged, hormone loss. And I also think the metabolic implications and the downstreams effects on chronic disease. So insulin resistance, bone loss. I mean, I think it's unfortunate that for people who can't use hormone therapy, the message is, well, we have a non-hormonal thing to maybe make you feel sleepy or to take an edge off the anxiety. So I think a pressing issue is really addressing how we can, help these people in a larger way.
I would also add to that, while I completely agree with sort of those priorities, some of the areas we really struggle and do not have good treatments in that really widely affect women are the brain fog and cognitive changes that we see, and then the sexual dysfunction that we see. Low libido, and even though we have FDA-approved medications, we have some off-label medications that can be helpful, it's such a complex field and topic that encompasses so many different arenas when we think about sexual dysfunction. But even the medicines we do have aren't that great, transparently, right? And then for brain fog, same. Some women do get improvement when we think about hormone therapy. It's not consistent in the research, and very likely it might be because we improve sleep or hot flashes or something else. But then apart from that, a lot of what we're advising are the lifestyle things, right? What can we do to reduce stress? What can we do to, are we exercising regularly? All of those pieces. But if we're thinking about pharmacologic targets, we don't have a good medicine that's going to be the most helpful there.
Hormone therapy probably is, and anybody who has had severe symptoms and you put them on menopausal hormone therapy, I actually think that is the biological answer, but I think there's huge populations of people who maybe don't have that, and I also think that we ignore testosterone in women, and we desperately need more research on what that means. Not to say that you should believe everything you hear online, that testosterone is your miracle thing, but I think it's been an overlooked hormone in women, especially women who lose ovaries. Yeah.
Yeah, and also to add to that, firstly, we need you. Thank you for doing this work.
Yes, thank you.
Kudos to you. But just to say, you hear that we are just scratching the surface. There is so little funding in this from the NIH. It's amazing. And what we don't have is this, quote, special populations. We have really, like you said, not just prevalent, like how common, but how severe. So somebody goes through really early premature menopause, whether it's from, surgery or their genetic susceptibility, women who have other biological conditions like PTSD or polycystic ovarian syndrome. You just keep going, find a condition that affects women, and then what happens when they intersect in menopause, we really don't know. And so there's so much work to do. So if you can contact your local senators, advocate when they say, say, this matters to my, everybody knows somebody, sister, parent, spouse, keep going themselves for whom this is relevant. And so we need to advocate this as a priority.
My question is, how do you feel about these direct-to-consumer labs? How do you feel about saliva tests, urine tests that are out there? And do you think there's any utility to them?
I've been practicing menopause management for years now, and I've never used a saliva test, and I've never used a urine test. I understand why they've been made, though, because women don't feel heard and they don't feel believed. And so if a woman comes to me and says, oh, I did this test, or I don't make them feel bad about it or even say that it was wrong for them to do, because if it gave them some information, that's okay. I will never vilify a woman who wants to do that. So the fact that they're out there tells me that we're not doing a good job of treating the general population. And if a woman asks for something like that, I'll just explain why I don't find those tests useful and why, sometimes a blood test is helpful. And honestly, if someone wants to know their estradiol and FSH, I'm not gonna fight them on it. That's okay too. We don't have to say no, I never do blood work. It's okay, but just understand what value you're going to get from that test.
And then I think it's also important to know, what are we going to do with the test, right? If we're ordering the test, you're paying for it, what would be the purpose of why do we want the answer?
Yeah.
And often having those conversations to say, well, what's the goal of this, can also clarify that maybe you don't necessarily need it. In some cases you might need it, but maybe getting to why do we want it in the first place is also critical.
I saw 9 different providers trying to figure out what was happening with my body when I awoke with dark fine hair covering my cheeks and neck, and at the threading salon the esthetician said, "Oh honey, it's the hormones." And luckily Dr. Iyer is my doctor now. And so I thank you. But my question for all of you is, how do you feel about required continuing medical education for doctors, nurse practitioners, and physician assistants who treat women? And just one more thing, I'm recovering from my second total knee replacement in a 4-month period. And I go to an amazing orthopedic practice here in Boston, but that practice advises women to stop their hormone therapy before surgery and after surgery. And I had to consult 3, I have access to doctors, I'm fortunate because of the work I do. I consulted 3 Menopause Society certified physicians, including Dr. Iyer, and a hematologist, to bring that information to the orthopedic so that they could sign off on me to continue my hormone therapy. How do we correct this problem?
Wow.
So, thank you. When we were just in Albany together in New York State to advocate for some education reform, I think that we have to tackle it from a lot of ways. And, one thing to think about, and you should ask your legislators this, Medicaid and Medicare is what funds residencies. So if you have an accredited residency and your residency cares for women, and those women are over the age of 18, I don't care what specialty it is, there should be, and I get it, there's so much training that doctors need to do, and there's so many emerging things that they need to keep up with, but it is not unreasonable for there to be basic things that all specialists understand about the menopause transition, just like every specialty that the surgeons know, okay, this is how you deal with a pregnant patient if they need surgery. Well, you should be able to know how to deal with someone who's on menopausal hormone therapy, for instance. So I think the residency training is really key, and basic medical school, basic curriculum. Like, not every person's going to go into menopause management. They don't need to know the ins and outs. So I think that's important. And then I know at the state level, there are some states looking at requirements for licensing and stuff, and they will get pushback from the medical societies for that, because doctors also feel very burdened by the administrative load of unpaid labor and all of that. So there's a lot of things to think about. So I think when we can ingrain it into the education, I think is the most important way. But
Yeah, and to add the comment about the continuing medical education, I think, many people won't get it as residents, and obviously, people who completed their training years ago don't have that opportunity. So anytime there are, we have to do credits every year. Nurse practitioners have to do it. Other psychologists have to too. The more availability for that, the better. So I think we're all going to agree with you on that.
And I will say a positive note, I'm board certified by American Board of OBGYN, and the last 2 years, there's been a big uptick in the amount of required articles. We have to read articles every year, and every year there's been excellent menopause articles. So I do think, at least in the OBGYN world, we're seeing that in terms of our credentials each year, which is a good thing.
My question to you is, as breast cancer screening has been being more aggressive, we find DCIS very frequently in women's diagnosis. How can you give me advice how to give counseling on perimenopause and postmenopausal patients who get diagnosed with DCIS? Is there any patient profile or pathologic features that a clinician should be more comfortable diagnosing MHT, menopausal hormonal therapy, or do we have to have more oncology aggressively involved, because I'm seeing so many patients with DCIS?
Yeah, it's a great question, because that's the thing, when we screen more, we diagnose more earlier, which is great. We want to diagnose breast cancer earlier because the treatment burden of a later stage breast cancer, not only prognosis, but the burden of treatment is much harder, right? So the great news about DCIS is it's very, very great prognosis, right? And there's a lot of ways we treat it. And so the DCIS question is a perfect example of why we cannot treat the millions of breast cancer survivors the same. You can't just get a big pink X on your back because you had a diagnosis of breast cancer, and we can never talk about hormones. We have to look at individual cases. Someone who had DCIS, who had a bilateral mastectomy, because some women will choose that even though they don't have to, those women are never put on hormone blockers. They don't get tamoxifen. Stopping their periods or lowering estrogen is not part of treatment. So why maybe a few years later when they go through menopause after having hormones for a bunch of years from their own ovaries, can we not have an intelligent conversation with her about her options for hormone therapy? That's one very easy example. And then we've got patients who have lumpectomies, radiation, and they have still breast tissue. And so you're going to have a different conversation with her depending on what's her risk of recurrence, of a new primary, what are her genetics. So I just think, obviously it's a complicated question, but it speaks to the idea of these women deserve nuance, not prohibition. And so without having, we could spend 3 hours talking about this, but that's how I would approach it, and it has to be a team approach. And don't be surprised if at first the medical oncology team doesn't know, or they're a little bit uncomfortable. I find that when you build bridges and you say, here, I evaluated her, and actually this is what I think, and I'm willing to prescribe for her, or I'm going to offer her X, Y, Z. What do you think? They're like, oh, okay, well, that's cool. I like that. They understand it, and give them a few articles, et cetera. So there's a lot more literature and consensus statements being put out. So I'm very hopeful that it's moving in a positive direction, and also knowing that we have new non-hormonals for these patients, and they can always use vaginal estrogen. But we're going to talk about that later.
Thank you.
All right.
I would also just add really quickly to that, one of the things I like to do is put the actual study results in my notes. I will put every study we talked about, all of the results, I will quote everything, and then when I message colleagues, I will say, please look at my note for everything else, and then everybody else who wasn't even not taking care of maybe potentially a menopausal symptom, but primary care or gastroenterology, they're also reading this, right? So I think that's also really helpful when we think about educating our colleagues.
And I'll just add, I know we have to wrap up soon, but I want to just add one thing, which is that we should always be thinking about options for people's symptom management, regardless of their personal history. Some options are not, of course, reasonable candidates. But it should never be, there's one gold standard, and then there's other options if that gold standard doesn't help. There is no other field in medicine for the most part. We don't treat hypertension, blood pressure like that. And it's just really, really important for our breast cancer patients who feel like they have second best option. That is not true. We have done more head-to-head studies. There are really good treatments for people, and they should feel empowered that the treatments that they're eligible to take are going to be effective, whether it's hormones in the case like this DCIS case or not. The importance is that there are options, and people should know what the options are, and they should not feel like they're only getting the second best.
Thank you. Dr. Jaffe, Dr. Iyer, Dr. Men, thank you so much. So let's welcome our panelists to the stage. Dr. Robin Noble, board-certified OBGYN, Chief Medical Advisor for Let's Talk Menopause and practicing physician at Intermed PA. And Dr. Wen Shen is a board-certified OBGYN, Associate Professor of Johns Hopkins School of Medicine, Director and Founder of the Johns Hopkins Women's Wellness and Healthy Aging Program. Thank you both. It's great to see you both here. So let's start first of all, Dr. Noble, with you. The history of menopausal hormone therapy research, and how did we get to where we are today?
I don't know how far we want to go back.
We're going to have to go all the way back.
Is this one working?
I think so, but
Yeah.
if it's, is it?
So
Okay.
I think what's really important to have that perspective, and some of us who have been in this business quite a long time, the perspective is valuable, and kind of the views of menopause, hormone therapy, where it can be helpful and where it's maybe not helpful. And I think the longer I spend in medicine, the more I see that things can be a pendulum. And people can think that everything is fabulous about something, it's the greatest thing, and then people say like, actually, no, maybe not. And we've seen this happen with things like calcium supplementation. And hormones, I think, are not that different. And I worry when we're in a time of kind of trends and everything else that the details get lost. But in the 90s, when I was training, we actually thought that hormones were best for everybody. And somebody at 65, 67 would come into the clinic and we would say, oh my goodness, we should put her on hormones. That's what we were doing because we thought it was cardioprotective. And we actually really thought we were doing the right thing. And we probably helped protect a lot of bones back then. But it turned out that not all regimens were the same. Not all patients were the same, and there was actually some risk to adding hormones later. So then the WHI came out in 2002 that really said, hold up, stop, there might be some increased risk here. But what was missed is that they looked at populations, the average age in that study was about 63. And so they then made this assumption that it's not good for all these people, missing that maybe younger people with earlier starts could have some real benefits. So I think that was the big issue with the WHI, that we found that it's not necessarily good to start it for everybody all the time. But now we've gleaned over the last 2 decades, and sadly we've talked about kind of all the dismissed women, sadly, the lack of research, looking at this with a very narrow lens. But we've now come back to a place where we've seen the black box label come off. We've seen, a resurgence in prescriptions, which is great. Now we've seen shortages in patches, and we're having these big swings. And I think what gets lost sometimes are the details. And the details and the people and the individual and that shared decision-making and that autonomy is what I think is the time why, our first panel that did such a beautiful job talked about that nuance, that desire to give that nuanced education and options to people is, I think, what's really important. And I'd love to hear what Dr. Shen thinks as well.
I think in that study that you were talking about, WHI study, we had 40% of women in this country, right, on hormone therapy, dropped down to 4, maybe we're just creeping up to 5 right now, even with everybody's algorithm.
That swing.
that swing.
That pendulum.
That swing. So Dr. Shen, let's talk about menopause hormone therapy and what you have seen beginning with understanding systemic versus local.
So as you all can see from all my gray hair, I've been in this field forever, right? So
your beautiful gray hair.
No, I tell my people who ask me, why don't you get your hair dyed? I said, well, this is a result of raising 3 millennials. I've earned every single one of these, okay? So anyway, yes, I've seen this huge swing, and I was getting my training a whole decade before you, and we were basically handing out, I won't say the commercial name, but this combination estrogen progestin pill like it was sugar water. And we got exactly 1 hour lecture during residency about menopause, because menopausal women, as OBGYNs, you can't have babies, you don't need to make babies, and if you don't have cancer, we don't need to talk about you, right? So menopause hormone therapy is a term that I use. I seldomly use HRT because I get very confused when I read papers on oncology where there are certain types of hormone therapies that are given out for different cancers. Also, we have a large population of transgender people at Hopkins, and they're also on HRT. So I prefer to use menopause hormone therapy because then I know what I'm talking about. Menopause hormone therapy in the United States traditionally means estrogen and progestins. And one really important point that I want to get across to everybody in this room is that not all estrogens and progestins are created equal. And this is where we go back to that nuanced treatment care, because there are definitely estrogens and progestogens that are safer for menopausal, postmenopausal women than the other estrogens and progestins that are traditionally found in birth control pills, okay? And so you have to be very careful. You can't use all the risk factors as a blanket term. And that was part of the problem with the whole FDA black box. They put all hormone therapies into one black box, and that was just not right. So traditionally in the United States, estrogens and progestogens, although in other countries, I wish we could be more advanced like England and Australia that have so many other formulations and also different androgens available for women, but we don't. So with regards to estrogen and progestogens, in birth control pills, they tend to be synthetic and they're much stronger. So they do also carry a lot more side effects and risk factors, such as causing blood clots and other issues for women who take them. Menopause hormone therapy, the majority of which that's prescribed in the United States nowadays would be 17-beta estradiol in the transdermal form, meaning it's either a skin patch, a skin gel, or a vaginal ring, okay? And then the progestogen is primarily natural micronized progesterone, not the synthetic progestins that are in birth control pills and also in the combination hormone therapy that was used in the WHI. So a lot of patients come in with preconceptions about menopause hormone therapy because of all the misinformation that came out from the WHI. So I spend a large part of the first consultation dispelling them of the misinformation. And it's rather unfortunate because so much good information came out from the data, but that came out later and with a lot more analysis. But the initial blast on the New York Times scared the heck out of everybody. And so that was pertaining to one specific formulation, which we hardly ever prescribe anymore. So the 17-beta estradiol and the natural micronized progesterone are the exact same estradiol and progesterone molecules that a woman's ovaries make. So a lot of patients who come in saying, I don't want HRT, I want bioidenticals. And so there's also misunderstanding out there about bioidenticals. And so I asked them, what do you mean? What do you think bioidenticals are? And the patients would tell me that these medications are made from plants. They're not from synthetics from a lab. I said, okay, so how do you think they get the estrogen from the red yams into one pill? And if you want to get the equivalent dose of estrogen from eating red yams, how many red yams would you need to eat in one day? So and they go, oh. I said, so what you're talking about, the bioidentical, is also made in a lab. It is also, it's those molecules that work on your estrogen and progesterone receptors in your body, okay, that helps your symptoms. And so what I would prefer for myself is an FDA-approved hormone prescription that has gone through efficacy and safety trials, okay? It's like so nobody's a big fan of the FDA these days. However, at least the menopause hormone therapies that have gone through their evaluations have safety, and we have experience about what are the most common side effects, what to do about them when they happen, and what sort of risk factors to discuss with the patient, whereas the compounded combinations, and there's just an amazing number of combinations of not just estradiol, but estriol, estrone, you know, every type of estrogen that you can think of that don't really have good data information about them, compounded in the back room of a pharmacy without, very often without certification, without safety evaluation. And so, you know, I'm not saying that they are all bad, but buyer beware, right? Just like when you read about certain hormone therapies online, buyer beware. If somebody is trying to sell you something, lotions, potions, and eye of newt, watch out, right? So, all right, so that's menopause hormone therapy, and that I'm probably overdid my time already.
Never. You never. Never, never. One quick question. Let's talk about systemic versus local, just the medical terms and understanding that difference.
Oh, yeah,
Yeah.
I was supposed to talk about
That's
that.
okay.
Wasn't okay, so
It was so much more interesting what you were talking about.
systemic means the estrogen and progesterone that you are using is absorbed and goes throughout your body and affects every estrogen and progesterone receptor in your body, okay? Your brain, your bones, your heart, your muscles, your urogenital tract. I'm being G-rated here. I have been known to be X-rated in my...
You can be X-rated.
But no, my sister is in the audience. She would kill me. So the thing is, so that's systemic, okay? And so a lot of the benefits that people talk about with regards and a lot of the risks about menopause hormone therapy relates to systemic, okay? The local estrogen therapy very much addresses urogenital symptoms, the genital urinary symptom of menopause, and GSM, because that's a big amount. And that is very low dose, 10, for the most part, the formulations are 10 micrograms of estradiol or less. And so lots of clinical trials have shown that they are barely, if at all, absorbed systemically. So their benefits are to the vagina, the vulva, the bladder. And we know that those are very, very severe symptoms for some women. Some women get recurrent UTIs and end up getting kidney infections because of urogenital changes after menopause. And so, and for the FDA to have had a black box on that all these decades is just a sin, because so many women were suffering, and if they've had breast cancer, they were scared to go on this, even though I kept on trying to tell them it's okay. And I even got the oncologists at Hopkins on board. Took a bit of doing, but they finally, I sent them enough papers, they agreed to have, you know, all these patients on aromatase inhibitors. I mean, those are miserable medications. And this bit of improvement in their quality of life, local estrogen is you know, I give it to almost everybody. I've got 80-year-old ladies on it, and whereas, you know, they're asked, why are you on it? Well, does she have a vagina?
Dr. Noble, benefits of menopausal hormone therapy. Let's talk about the symptoms that it can treat.
Yeah, I mean, I think what's so important, you know, reinforcing our first panel, is there's such a variety of symptoms, and some people have almost all of them, and some people have almost none of them. And so, you know, hormone therapy is really, you know, replacing in a way, or adding back a little bit of hormone when the estrogen levels really go down. So if someone around this transition has started to experience all these new symptoms, if it's not other things that are happening in their life, if it's not other, medical issues that are ongoing, many of those symptoms are going to respond to hormone therapy, menopausal hormone therapy. So if it's, increased anxiety for that person, that might improve. If it's sleep disruption, that might improve. But Dr. Jaffe, reminds us that there are lots of other reasons why people can't sleep. And if they've had pre-existing insomnia, then giving them hormones is not likely to address that pre-existing insomnia. What I love about taking care of patients during this transition is it's a little bit of detective work. When did this stuff start happening? What are the new symptoms? If they present with, shoulder pain and more hip pain all of a sudden, that's likely going to respond. And it's actually also a really good barometer to assessing how they're responding. If they come back in and they say, actually, my shoulder pain and my hip pain is better, but it's still there, maybe that suggests that we go up a little bit more. But if they now have new onset symptoms of, say, bothersome breast tenderness, maybe that's your guardrail to say maybe we bring it down a little bit. So it's really, kind of the art and the nuance of like what symptoms they have, what has evolved over time, where that intersection of kind of chronologic age and the menopausal transition and kind of situational aspects of their health, they all intersect. But we can see musculoskeletal improvement, we can see mood and sleep improvement, some of that brain fog that especially if gotten too early at that transition seems to be more helpful. If someone's 5 years down the road, we don't think it's as helpful for things like brain fog and mood symptoms. So there's a critical kind of timing and window where some of these things respond a bit better. And then there's a lot of areas we need to research more, things like longer-term osteoarthritis and inflammatory symptoms. So I think it depends on the person, it depends on their symptoms, but a whole host of new onset symptoms that start to crop up, those palpitations that we see. And I think, it gets so important whether it's the perimenopausal symptoms, which is this phase where we have real roller coasters of hormones where people have highs and lows and they get different symptoms from the really high levels and different symptoms from the really low levels. And frankly, it's much easier to manage menopausal symptoms when the hormones have flatlined and you can just bring up the levels. So I think it's where they are, what their symptoms are, and then incredibly important what their philosophy and preferences are. If this is their most important bothersome symptom, it helps to kind of narrow in on that. And I think we've got to look at all the tools in our toolkits. We've got to look at the GLP-1s because for some people, you get more bang for your buck if it's really the weight and the metabolic symptoms. And I don't think there's this one size fits all. I don't think people should be fearing that they're missing out. I think we need to tailor it to the person. And I think one other thing that's really important to me is we've talked about so many women who have felt dismissed for so many years, but I think the other aspect is, and why this awareness is so important, is there are a lot of people that are kind of they have silence. They don't see symptoms. They could transition into menopause at 40 and not know it's a problem. So I think if I had, my wishes, it would be that everybody has this information that knows it's a critical window into your health, into kind of the years beyond, the decades of, the impacts on our bone health and our cardiovascular health. So it's for the women who have symptoms, but it's also about the women who don't really have bothersome symptoms, and they sadly don't know they should be getting more options.
Yeah, I wish there was that baseline somewhere in there that was a real standardized baseline. Like I think I lost my mother to breast cancer and she was 51, but she was diagnosed at 44. So they backed me up, 10 years. So I've been paying attention to breast health and mammograms since I was 34 years old. Perimenopause, none of that ever came into any conversation. So I wish there was that kind of number in all of our heads of, hey, I should go be talking to somebody about this.
And sadly, as doctors, too many people are kind of laser focused and they look at somebody through one lens, and it really matters that we're more holistic about this. Like Dr. Iyer, these centers and Dr. Shen's center, looking at the whole person and looking at what they want and what is, perhaps a good trial or option for them.
Yeah, you're so right about that. Dr. Shen, let's talk about this, when of being able to take hormones. Women can start taking hormones in perimenopause. They don't have to wait until they've hit that 365 days without a cycle. Can you talk a little bit about that?
Right. So some of the worst symptoms tend to occur to a woman's in perimenopause, because that's when your ovarian function is just all over the place. And to back up what everybody else was saying, that's why getting hormonal levels when you're perimenopausal is just asking for confusion. So if you are in your 40s and you're having all the symptoms that correlate with perimenopause, and you don't have any other ongoing comorbidities like thyroid disease. If you do have thyroid disease, I will ask you to get everything evaluated with your PCP first. And then, yes, you would be a candidate for hormone therapy at perimenopause. For women who are perimenopausal who need contraception, yes, you can still get pregnant in your perimenopause, okay? I had a nurse who got pregnant at 50, and she was just, right? But the worst part of it, though, is because of the increased rate of pregnancy losses when you get pregnant at that age. And so she was so upset about being pregnant at 50, and then she lost the pregnancy and she hated herself. She thought she had wished that on her. So it's not just the physical pregnancy, but it's also the mental trip. But anyway, so if a perimenopausal woman is having symptoms, she needs contraception, I will absolutely say the first line here is birth control pills. Okay, birth control pills are made up of estrogens and progestins. And so they can take care of a lot of the symptoms of perimenopause while giving you that protection. Another option that also works really well is the levonorgestrel IUD, because many perimenopausal women, one of their first symptoms is abnormal uterine bleeding. They're just having periods all over the place, and they don't know, they can't plan for things because they never know when it's coming. So the levonorgestrel IUD is really effective in controlling menstrual periods. 80% become, don't get a period at all while they're on it. And then we can add the 17-beta estradiol on top of the IUD. The IUD and also the progestogen is the first purpose of the progestogen is to protect the endometrium of the uterus from the stimulatory effects of the estrogen, so the woman doesn't get hyperplasia, increased risk for breast cancers. So, but progestogens also have other benefits for menopause symptoms, and for a lot of patients, it does help with their sleep, although it's not the, doesn't address the roots of their sleep issues in menopause, but it does help a lot of women with their sleep. So that's why you have the estrogen and the progestogens together. And so perimenopausal birth control pills, totally fine. The levonorgestrel IUD, totally fine. And menopausal hormone therapy, totally fine if she is not in need of that contraception. And so I always give the husbands a kudo when the patient says, oh, my husband had a vasectomy. Right? He's doing his share. So yes, all of those options are yes, depending on the specific woman's risk factors and depending on her symptoms. And if she's ever been on birth control pills in the past, and if she had side effects on them, then okay, maybe we don't talk about birth control pills. But we also need to be aware that there's so many new options for birth control pills now, and with very different progestins in them that have a lot less side effects. So there's a whole, panoply of options out there.
Thank you. Dr. Noble, what risks do women need to consider, parameters around who can safely take systemic menopausal hormone therapy?
I might just go back a second for the perimenopause, because so many women during this time do have other comorbidities, and they do have maybe elevated blood pressure or migraines or things that might put them at increased risk of clot or stroke or make them kind of a less ideal candidate. And I think, many of us here take care of the most complex patients that might also have a higher than average risk of, say, breast cancer. So by no stretch of the imagination is this simple. You really have to look at all of these things, but there are very few contraindications to the menopausal hormone therapy, because that's giving back these bioidentical hormones that actually have less risks than some of the other ones in, say, birth control pills. They're a lower dose. They're generally not taken oral. Our preference is to give them through the skin, because when they're given through the skin, they don't seem to have that increased risk of clot or stroke. So there are very few contraindications to the hormone therapy in menopause. More complex, frankly, managing the perimenopause, when we're sometimes we're needing higher levels perhaps. But those contraindications currently in the US, and I think this is still an emerging landscape, are people who have had a previous myocardial infarction or heart attack, or they have an elevated risk of atherosclerosis, cardiovascular disease. But I think even that's being revisited because we don't understand all the nuance about it. And there are other countries where now a previous heart attack is not a contraindication. I take care of a number of people that have had things like a pulmonary embolus or a significant blood clot, where traditionally people just kind of like what Dr. Men said about the red X on the back. They sometimes look at these patients, they say never, ever, ever. And what they're not looking at is how different that is from, say, a birth control pill. So many people will hear from doctors, you can never use estrogens, when they might have been 35, and that translates, or it becomes, a big issue where they think that this is off the table, and it's not always true. It doesn't mean it's not a complicated decision. It doesn't mean that it's not requiring shared decision-making and autonomy. But some of these people who have a thrombophilia, which is kind of an increased genetic risk to having a clot or stroke, and they might have double, triple, or 4 times that risk of a clot or stroke, they might still be able to consider a very low dose of hormone therapy. But the big ones are, for the most part, hormone-sensitive cancers that we've spent some time, but even that is being liberalized because not all breast cancers are the same. The stages aren't the same. The time since that diagnosis isn't the same. So I try to tell people, I'm not the type of doctor that says absolutely no. You need to understand what goes into the decision-making. And the same thing we see on a day-to-day basis is the people that come to us now 10 or 15 years outside of this transition. And now people are hearing, not more than 10 years, not over the age of 60. And not every 60-year-old is the same. Somebody who's incredibly healthy and a vegan and is at tremendous risk for osteoporosis is very different from somebody that is still smoking, morbidly obese with diabetes. Their risks are different, but so I don't really know if I have these absolute contraindications to hormone therapy, but the big ones would be a previous blood clot or stroke, a thrombophilia, that increased risk, a hormone-sensitive cancer. And am I forgetting anything, Dr. Shen? I mean, these are the ones we get more concerned about, but I think even that requires individualization.
And then let's address family history, which I know you get asked about a lot. That is not one of the contraindicators.
Yeah, family history is not a contraindication. It's actually, it helps inform us to what that person's risk is. Because family history is interesting because it's not only our genetic risk, but oftentimes it's our environment too, which is an incredibly powerful predictor of even things like dementia risk. There are a lot of gray zones here and a lot of kind of voids and data-free zones. Dementia is something that really, is tremendously important to all of us, especially the burden of caregiving. And we don't have enough information about this, but we do think there's certain scenarios, certain regimens that might be more concerning for dementia risk, like a late start with estrogen and progesterone versus early starts with estrogen alone are cognitively protective. And I think one thing that hasn't come up here so much yet is that when someone's undergone a hysterectomy, they only need that estradiol. And it's so much more favorable estrogen alone because it doesn't seem to increase the risk of breast cancer. In fact, there's some data that there's actually a decreased risk, certainly with kind of the Premarin that was used in the WHI. But so the person is different, their scenario is different, their family history is different, what they're really at risk for needs to be taken into consideration. Because even if they don't do hormone therapy, we want to educate them about the benefits of strength training, bone health, doubling down on the lifestyle factors, but we really want to look at that person holistically and look at what their preferences are, what their symptoms are in the time frame, and then what they, want to avoid. And if they can come in and say, I'm most concerned about my bone health, it helps us kind of zero in on what's particularly helpful for bone health.
Thank you. Dr. Shen, the recent announcements from the FDA regarding the changing the estrogen guidelines and removing the black box warning. Talk quickly about that, but also discussing this patch shortage, this estrogen patch shortage, and other options that are out there right in the time being while we figure this out.
Right. So with regards to the patch shortage, I feel so sorry for my nurses who are constantly trying to negotiate that for my patients. What I advise patients to do is to call around to all the pharmacies in your neighborhood to see who has any, okay? So that's a lot of homework that the patient has to do. She can also go on to Amazon or Costco, one of the big box people. They may have better supply than the local pharmacies. If they absolutely, and then there's also the Canadian pharmacies, okay? I can give the patient, send her a paper prescription, and she can sign up for Canadian pharmacies and have hormones mailed to her from Canadian pharmacies. Okay, so anything outside of that, then there are other hormonal estrogen options that are transdermal, as I said before. She can always switch to an estradiol gel or the estradiol ring, although that's harder to get approved by the insurance companies. And for short-term purposes, it is not the most horrible thing if she were to convert over to oral menopause hormone therapy until the pharmas ramp up their production to catch up with demand. So there are many different options. Obviously, if there is a woman who has had a blood clot, who has had, a stroke, so she would be somebody that I would be very hesitant to switch over to oral because of that increased risk of coagulation because of the hepatic metabolism of oral estrogens. So there are different options, and that's also a conversation, but there are definitely other options available. The patient just does have to do quite a bit of homework on her own to find a pharmacy that does carry them. But most, at least because I'm in a relative size city of Baltimore, there are more options around for people who are living elsewhere. It might be more difficult.
My concern is I'm getting a lot of messages from women who have just stopped because they don't know what to do. And that's, I don't know if we can address that just briefly before we move on.
Yeah, the mail order pharmacies, so far Costco and Amazon have been, I hate doing commercials for them, but they do seem to be more responsive and have more availability. And so, and that they can mail anywhere.
Okay, thank you. Let's go into testosterone, Dr. Noble. Let's talk about it. We have a testosterone fan club. I'm among them. Who's a candidate and what is it used for?
Yeah, I think we'll find that probably anyone is a candidate for it, unless they have, pre-existing elevated testosterone levels from something like polycystic ovarian syndrome where that's problematic for them. But for the most part, I think understanding the biology of testosterone, and again, we need a lot more research, but testosterone, is not a menopausal hormone change. Testosterone declines over our lifetime, over the decades, like from our 20s, 30s, 40s, actually, gets to its lowest point around the age of 59. And there's some newer research that says actually that it seems to actually increase around age 70. So think of it in the background over our lifetimes, and it has, various impacts on, sexual function. There are receptors in many areas in the body. It is one of the drivers of libido, but libido in women is so complex and it's so multifactorial that it's not usually the whole answer. So the way I look at testosterone is it is another tool in our toolkit. It's not abruptly changed, with the exception of, say, when our ovaries might have been removed surgically, because then it does, as Dr. mentioned, drop by about 50%. 50% is also made in the adrenal glands. So I think it's important to look at in the context of what the symptoms are, what the desires are, and coming back to kind of autonomy. If people feel that something might be missing and they maybe want to try something, if it's done judiciously, and that's one area where we really do think hormone testing is indicated. And it's not so that you can determine who can be a candidate, but you want to know where that person started from, and then you want to treat them judiciously. Because there is no current FDA option for women in the US, we actually have to come up with these kind of cookbook ways to use either 1/10 of the men's formulation or use a compounded option. So that's an added barrier, not to mention the fact that it's actually still considered a controlled substance. So it requires at our offices more hoops to get through, and I have pharmacy pushback because they're not as comfortable. So the prescribing of it is complex. It's challenging. There are additional barriers, and I think we're just starting to see it get more mainstreamed. It's also got some interesting applications for our breast cancer survivors because the profile is likely safer. I mean, I think definitely safer, we could say. And there's some interesting aspects to possibly hot flashes. Libido is where it's really kind of stood out. And it's not going to be a huge factor. It's going to have a little bit of a lift, but there's also a powerful placebo effect in things that we do, number one, but also feeling that we have an option that we can try. So for those women that might be outside of that 10-year window that feel they're not a good candidate for traditional estrogen and progestogen, having an option that somebody can try and see, is this important to me? Is this something I want to do? But do it safely, do it judiciously, and understand there are a number of hoops we're having to jump through because it's by no means easy to write for this right now.
I feel like on every front we have hoops to jump through, right?
Yes, we're very good at hoop jumping.
So in addition, just with regards to testosterone, because of the hesitancy of the mainstream medical system in prescribing testosterone to women, a lot of women are going to functional medicine sites and other sites and getting testosterone pellets inserted. And in order to avoid a patient exposing herself to that risk, I will say, okay, let's work on this together. We'll jerry-rig the testosterone that's FDA approved for men, but not for women. But don't go and get those pellets because the NASM, which is the National Association for Science, Medicine, and Engineers, actually came out with statements a few years ago saying that they do not advocate for it because there is no safety data to back it up. And I have seen many women come to my office having side effects because they had pellets inserted. And once the pellet is in, you're stuck with it for 6 months, maybe more. They can't remove it. And if you start getting abnormal bleeding, if you start getting other side effects, there's nothing you can do about it. And so it does make the woman feel great at first. She's just like, wow, but in the long run, it can have severe medical complications like blood pressure, like cardiovascular changes. So
Not to mention hair growth and some of these other things. I mean, I've seen levels as high as 350 come in. And the other aspect is many of these people are not being effectively counseled. So it's a profit center. I explained to them, it doesn't make sense to me because, again, you can't get it out. You can't adjust it. They're buying these. They're getting preyed upon, sadly, from outfits that are making money that way. So we want you to feel that you should have access to testosterone. It's tricky right now, but we don't want you resorting to something that can cause I've seen chest hair, permanent deepening of the voice, hair loss here, rage.
Wow.
Yeah. So a lot of these centers, they'll insert the pellets, but if the woman starts having side effects, many of them don't even have an MD on site. So they get told, go see your OBGYN.
I made the mistake before I knew all of you brilliant doctors several years ago, and I was crawling all over my husband, for 6 months, and then I think like the 7th month, I'm like, don't come near me, don't look at me, so yeah, it goes up and then it goes down. Real fast before we start taking questions, and if you have questions, if you want to start lining up, how long can you be on hormones, Dr. Shen?
Forever.
Okay. I knew that was going to be a fast answer.
unless you develop estrogen-dependent cancers
Sure.
or the other major contraindications.
All right. We have some questions starting, I think, online ones.
How do you address prescribing MHT for women who are not experiencing physical symptoms but have labs like cholesterol or insulin? Yeah, if you're not exhibiting symptoms, how do you do that?
So menopause hormone therapy at this time is not recommended for preventive issues. It is the primary indication for menopause hormone therapy is for moderate to severe menopause symptoms such as vasomotor, night sweats, okay, irritability. But there are many women who feel very strongly that they have medical conditions that can be helped. And there is data from research that by being on menopause hormone therapy does improve your insulin resistance and your cholesterol profile. So as long as the woman is aware of her risks and that, you know, it may not help at all, I will prescribe it for her, but with careful evaluation of her risk and a shared decision making.
Yeah, and I would just add, I mean, there are indications to do it for the prevention of osteoporosis. So I think it is valid for anybody to say, I want to do this. I'm, you know, mindful of my bone health, because we know what happens to bone in menopause. It kind of drops off a cliff. So we're behind in all of the research. We're not going to have all this prospective research for a long time. So I think we have to be in the moment and do the best that we can and recognize that there are other changes that might be important to that woman, like where her central visceral fat goes, what happens to her skin, what happens to her vagina, what happens to her bone. So I think we have to move away from what is considered an indication. Yes, it's not considered preventative for, say, cardiovascular disease, but you know, we don't know what the next 2 decades are going to show us, and we have to do the best we can in the moment.
My doctor won't put me on hormone therapy, even though I went through early menopause at 41. What should I do?
Find another doctor.
I actually went through early menopause as well, around age 41. I have a very significant background in exercise science and nutrition, so I am now a menopause health coach who focuses on the non-pharmacological things. However, I am a very big proponent of HRT, and I'm on it myself. But going through menopause at such an early age, it was a really eye-opening experience and led me down a road of trying to rediscover myself and figure out what was going to work for me going forward. And what I found that in a combination of the HRT and then doing things from an exercise and a fueling my body different perspective was life-changing. It was remarkable. So I know we're talking about menopause hormone therapy on this panel, but I'm curious how often it comes up with your patients, fueling your body, how to do it properly, how to do it differently, as well as how to exercise differently, which not only helps manage symptoms, but also helps from a cardiovascular perspective, helps from bone density perspective, muscle, all those things that are trending in this direction.
Yeah, so important. I mean, food really is medicine, and I think we need to emphasize this more. I'm boarded in lifestyle medicine as well, so certainly very interested in kind of the preventative aspects of diet. Again, this is another area where we're seeing all these trends and these, you know, pendulums, which I think we have to be mindful. I think we're in this protein craze that I don't think we have enough data to really suggest that's a good idea. I think adding powders and other things that you're paying for are not necessarily the best thing, but again, we don't know. I try to look to the areas in the world where people are healthiest and live the longest to guide some of these. But some of these things are intuitive, and we know that strength training and lifestyle are huge issues that, you know, that everybody should be doubling down, whether they choose to do menopausal hormone therapy or not.
So I usually send my patients out after their initial consultation with 3 very simple lifestyle practices. One is 45 minutes of walking, because you know you don't have to get all fancy about it. You don't have to go to a gym and
Get an outfit. You don't have to get an outfit for that.
And feel really self-conscious next to the 20-somethings, you know. So, but so walking is cardiovascular and it's weight-bearing. For the most important bones in your body, right?
And our brain, and being outside.
The cardiovascular, yeah. And and then I do advocate that women take vitamin D3, okay, even if they're levels are normal, I do recommend daily vitamin D. And then for calcium, I say do dietary, unless you have very specific GI issues that you can't tolerate dietary calcium. But, you know, there's just, when you say calcium, everybody thinks dairy. Almonds, leafy greens, fatty fish, lots of options. So between those three, you can really help keep your bones, your heart, and your brain healthy, and they don't cost a lot.
For those of us who keep getting told no, what's to make us, I feel left out. I feel like, oh, I still can't have that estrogen, I can't have the other things. And everyone's always talking about now how it protects your brain, it protects your bones. Yes, I'm doing the heavy lifting. I'm trying to do everything I can that's not hormonal to protect my brain, to protect my bones, et cetera. But I'm thinking, oh my gosh, compared to all my friends, am I gonna get dementia when I'm
I don't think there's good data for people to be saying that hormone therapy is protective for dementia risk. There are certain circumstances where we have better data, the estrogen alone, is as opposed to hysterectomy, but combination estrogen and progesterone, there are actually some studies that show it might slightly increase the risk of dementia. So I don't think you should be feeling like you're missing out on the brain health. That is a very gray area, and I think too many people are saying too many things about brain that are not well-founded. I do think that this no is negotiable. And I don't know enough about your particular situation to decide whether it's really not something you would want to do. I don't really believe in telling people no. I believe in explaining the whys behind it. So there's that. But I don't think this fear of missing out, I think if you're doing all the other things, those are going to actually serve you really, really well. And I don't think people should be feeling like they're missing out. And these breast cancer survivors, there's so many other things that we can do. But I also wonder if it's truly a no. I don't know.
So it might be worth it for you to get a referral from your PCP to go for that one-time consultation with, are you in Boston?
Yes, and I've already been to so many different OBs and or GYNs and my PCP, and they referred me to other people, even a hematologist. But thanks to journalists like Tamsen and doctors like you all and who write these articles that are online, I take these to these doctors, and I still get such pushback.
You know, I would recommend that you go to one of the menopause centers, like at Harvard, right? So many of my colleagues at Harvard, and these people have that specific knowledge, and they would be able to individualize your situation, because yes, unfortunately, there's still a lack of understanding in the community. Even in, you know, a community such as Boston, there are going to be a lot of providers who aren't up to date.
And how about the autonomy? You know,
Right.
I think women
Right.
need to push back and say, nobody's telling us not to get in our cars and get on the highway. And that might have more risk, it usually does, than actually taking hormones. And I think sadly, situations like this is what drives a lot of people to these compounding medi-clinics where people do off-label stuff, and you would be written for absolutely everything under the sun, not counseled about it. And that's sad that we're not serving people well. So I think we need to move away from the no's.
Should we be giving vaginal estrogen preventatively, right? Like 45 years old, I would say 80% of my patients that walk in need vaginal estrogen. Yesterday, I was yelled at by a physician because we asked for vaginal estrogen. It's still crazy in the state of New Jersey. State of New Jersey is crazy to begin with,
That's
but
crazy.
it's still crazy. This is happening. It's
Yeah.
happening. Thank goodness for the black box warning.
Yeah.
I'm so excited. So vaginal estrogen is a big thing. And should we be doing, I mean, we put facial cream
Yeah.
on our faces
I mean-
as we get older. We need to take care of our vaginal canals.
I mean, I would say it's always a balance, and, you know, proactively, maybe, if someone wants it. I tell people low threshold if we think we're even starting to develop symptoms, like very low threshold. But we also don't want more things to do if it's not gonna make a difference. So am I gonna put vaginal estrogen in someone who's cycling with no symptoms at 40? I'm not gonna give her one more thing to do twice a week.
Yeah.
But if anybody thinks we're right around the corner, might be slightly, subtly developing symptoms, absolutely. Low threshold, early and often, always, pretty much.
Yeah, and there are definitely patients who say, put something in my vagina every day or twice a week or whatever. No, thanks. So, yeah, it's up to the individual.
You briefly talked about like telehealth and online platforms. Is there a lesser of evils for that? Because the waiting list to get to one of the menopause centers is so long. Is there a possibility to help people in real life, like I'm meeting with them every week and they're looking for that? And it saves them from going and searching on their own. And I've had a few that have gone down a bad road.
So there are so many online evidence-based podcasts and webinars that patients can. So look up the Menopause Society,
Yes.
International Menopause Society, and also Society for Women's Health Research. These are my 3 go-to organizations that have excellent information for women, and they are evidence-based and they're very patient-friendly.
For sure, they're looking for prescribers though. They're looking for they're going to compounding facilities, getting those hormones a different way. Is there an online, I'll just throw it out there, like MIDI Health? What do you think about those kind of platforms as a last alternative while people are waiting or just can't get the number of times they go to providers and are turned away?
I have been getting quite a few patients who, while they were waiting for their appointment with me, went to MIDI Health. And I had to say that for the majority, I have no objections to what they were given. My contribution to that was to go do a deeper dive on their medical history. While doing that, I find that they're at increased risk for cardiovascular disease because of their OB history. So my contribution is to make sure they get in to see a woman's heart health specialist, and so just a more integrated medical evaluation. And and I'm lucky because my program does have all these other specialists involved, so that I can tap the patients into. But overall, how they've been treated by MIDI, I can't speak for others. It's been, my experience has primarily been with MIDI Health.
Dr. Shen, thank you. Before we begin, I want to do a quick poll of the room. So by a show of hands, who went through their 20s and 30s thinking that menopause was simply hot flashes? I'm going to put my hand up because I was so in that camp. But menopause is way more than hot flashes. But hot flashes have an excellent publicist, right? We think they are synonymous with menopause, and then we're surprised and blindsided by everything else. Welcome to a conversation that we are calling, Wait, Menopause Happens Down There? It's the vaginal, sexual, and urinary symptoms of menopause. We have a stellar group of doctors today. We are going to get into painful sex, low libido, bladder leaks, UTIs. You can expect tips for your sexual health, for your bladder and vaginal wellness. You're going to hear about top treatments that can really dramatically improve the quality of your life. I am going to be your panel's moderator. My name is Katie Fogarty. I am a board member of Let's Talk Menopause. I also host the midlife podcast, A Certain Age. That show spotlights women who are reimagining midlife. It features a lot of women's health content. I have interviewed a number of the doctors that you have heard from and will hear from today, but I have not yet interviewed any one of these 3 women, so I'm incredibly excited. I'm going to learn as much as you do. We'll be taking questions at the end. We're setting aside a healthy chunk of time because we know you have them. Try to keep them to questions that everyone in the room can benefit from. We know you've got questions. We want to get you involved. So I'm going to welcome our doctors in alphabetical order. We're starting with a Greater Boston area practitioner. Dr. Lynn Gray Meltzer is a doctor of physical therapy. She is a specialist in women's pelvic floor health. She is the president of the American Physical Therapy Association of Massachusetts, Pelvic Health Special Interest Group. She sees patients in Massachusetts and Arlington at Weeks Wellness, and she oversees multi-state clinical operations across 10 outpatient locations. We're welcoming back Dr. Corinne Men. As you know, she's an OBGYN. As a long-term survivor of breast cancer and premature menopause herself, her work bridges clinical expertise and lived experiences. Dr. Men is an active public educator on Instagram, TikTok, Threads, and Substack, where she translates complex evidence into accessible, actionable content for women. You can find her at Dr. Men, OBGYN. And then finally, from the Windy City, we have Dr. Samina Rahman, a gynecologist and menopause specialist affiliated with Northwestern University in Chicago. Dr. Rahman sees patients in private practice, serves women nationally in her role on the board of directors for the International Society for the Study of Women's Sexual Health, which is also called ISWITCH. You may know Dr. Rahman from her popular podcast, Gyno Girl Presents, Sex, Drugs, and Hormones, or from her Instagram where she regularly shares great science-backed health content at the handle Gyno Girl. Dr. Rahman is also at work on a book, so be sure to follow her on social media so you know when that book publishes. Okay, I'm gonna start with Dr. Men. Menopause can often add up to painful sex, brand new bladder leaks, what we sometimes jokingly call the sneeze peas, right? But there is nothing funny about these symptoms when they crop up. They're caused by the genitourinary syndrome of menopause, which people often refer to as GSM. Can you walk us through what GSM means to our bodies? What is shifting hormonally to lead to these changes?
Yeah, I think it's very important that we really explain to patients that it is a syndrome. And when I was in residency training, literally it was called the senile vagina. And then they also atrophic vaginitis, vaginal atrophy. But that's really missing the boat and not really explaining to women what's actually happening. And when we understand that there's estrogen and androgen receptors, that's where testosterone binds to, in our pelvic floor. You're going to hear about how important that is for pelvic floor health. In your bladder, your urethra, the vagina, but also the outside, the labia, and the clitoris. And that when those hormones decrease, we have this genitourinary syndrome of menopause, and it's really empowering for women to understand that the loss of estrogen and also some testosterone in these tissues leads to urinary symptoms, so urinary frequency, urinary urgency, frequent urinary tract infections, as well as sexual symptoms like painful sex, decreased lubrication, but also atrophy, so like decreased pleasure sometimes because less blood flow to the clitoris, less healthy tissue in the vulva, vagina, and the clitoris leads to decreased sensation and sexual function. So when we look at it as a big picture, we understand that even if you're not sexually active and maybe that's not something you're having problems with, you might have more of the urinary symptoms and vice versa. So really important to understand that new terminology.
Thank you. So let's do some more stage setting. Dr. Gray Meltzer, I think we need a brief anatomy review. At least I do. It's been a long time since I've taken high school anatomy. What are the key structures involved in sexual and urinary function, including the role of the pelvic floor, and how does menopause impact them?
So you're going to get my brief community workshop version here. So I want everybody to sit up nice and tall in their chair. Rock your pelvis back, rock your pelvis forward, tip side to side. See if you can center your weight right over these two bones in the base of your pelvis, technically called your ischial tuberosities, but most people call them your sit bones. So suspended between those bones is a complex network of muscles that as a group we call the pelvic floor. There's a deeper layer that oftentimes pelvic floor therapists refer to as the hammock because it not only squeezes, but ideally squeezes and lifts in response to pressure to help suspend and support organs. And then there's a more outer or superficial layer. It sort of looks like a combination of a triangle and figure 8 around the openings in the pelvic floor that sometimes we think of as more like gatekeepers. And we want balance. We want these muscles to be able to relax and be soft and flexible for things like comfortable penetrative sex, as well as be able to squeeze and lift to stop a bladder leak or to support the organs when you're picking up a kid or grandchild or weight.
Thank you. Dr. Gabon, sometimes women think they're done with menopause when the hot flashes subside, but managing our vaginal and bladder health is something we need to do like till the end of time. What are the long-term health and healthcare costs of untreated GSM, especially as they relate to chronic UTIs and bladder health?
This is a great question because, you know, as Dr. Min was saying, we previously called this, you know, vulvovaginal atrophy, right? So that just, you know, you're thinking about a wasting away of a vagina. But in 2014, when we included this urinary part, which is the genital urinary syndrome of menopause, we're realizing the real traumatic impact that our urinary tract has. So if you think about our geriatric population and the hospitalizations, about 25% of all geriatric hospitalizations are due to chronic UTIs or recurrent UTIs. And about 6% of those patients will die from their UTIs. So if we can figure out, you know, how to prevent this, I always, you know, we think about the transitive property in math where, like, you know, if vaginal estrogen is really important to prevent UTIs, and UTIs can prevent death, then vaginal estrogen really can prevent you from dying in those scenarios, right? Because we get a 50% reduction in UTIs. You might go from 5 UTIs a year to 2 to 3. And so if we see the cost of that in healthcare dollars, there's actually been studies to show it, that if we're spending about $2 billion a year from chronic UTIs or recurrent UTIs, and we treat people with vaginal estrogen to reduce those rates of UTIs, we can save, and each UTI hospitalization costs around $1,200. You have 10 to 20 million women that are on Medicare. You can save between $6 and $22 billion a year in healthcare costs by treating someone with vaginal estrogen, and so, or vaginal DHEA. And so I think it's really important to say, like, this is not just a feeling of vaginal dryness. This is not just being more aware of your vulva, which is what a lot of patients tell us. But this is actually a life-saving measure, that we can actually save those 6% of women who are dying from UTIs if we give them vaginal estrogen. And so I think it's really important for us to emphasize that. And it's oftentimes not even all in the geriatric population, because the genital urinary syndrome can affect people outside of menopause too, right? In lactation, when you have low estrogen, it's similar. For women who are on chronic birth control pills and we're suppressing their hormones, less than 10% of them develop something that is very similar to the genital urinary syndrome menopause. Women that have been on oncological or cancer hormone-reducing medications are also at risk. And so these syndromes occur in different times of hormonal vulnerability. And if we can reduce the risk of these UTIs, it's not only saving lives, saving those healthcare dollars, which is what's going to get more support from the government and all the agencies that we need to support us.
So chronic UTIs and death from UTIs are something we definitely want to avoid. Vaginal estrogen is considered to be the gold standard. Dr. Mann, why? Why is it the gold standard? How does it actually work? And is everyone in this room a candidate for it, particularly women who have estrogen positive breast cancer?
Yeah, so it's the gold standard because it's actually treating the problem. Like, so the cause of the genitourinary syndrome is the decline of estrogen. So, the guidelines, often speak about, particularly in women who are deemed to be quote unquote higher risk, or perhaps systemic hormone therapy is not recommended for them. They're told start with something non-hormonal, like moisturizers and lubricants. So I think the point of this question is to make sure that we understand that there is a difference between those three things. So very simply, moisturizers are great You can use them every day if you like, and they're going to increase hydration. They'll temporarily improve tissue quality, give you comfort. There's nothing wrong with using and starting with moisturizers. Lubricants are for sexual activity, either with a partner, with yourself, with a toy, any type of touching, whether it's external or internal. Lube is always a good idea and should not be seen. You should not see that as something shameful or, oh, I'm not aroused enough, so I have to use lube. No, lube should always be normalized. But neither one of those things are going to fix the problem of the genitourinary syndrome of menopause. Hence why I think sometimes, and this is my personal opinion, that the guidelines fail women when they tell them, you must wait till things are moderate to severe, and then you can request something that is FDA approved, we know is safe, and highly effective. So the local application of either, there's FDA approved vaginal estradiol, there's also FDA approved vaginal DHEA. Both are incredibly safe for all women. I would say there's a little small asterisk. There's a few very specific, there's a couple of GYN sarcomas that we're going to be very careful with. But even women who are on hormone suppressing medications for, say, breast cancer, like aromatase inhibitors, ovarian function suppression, tamoxifen, we have low dose, very safe, appropriate, FDA approved options that we can use. And I say it's a trifecta. You want the lube, you want the moisturizer, and you want the vaginal estrogen, and you also want to learn how our pelvic floor physical therapy colleagues can also support patients in treating the entire syndrome.
We're going to move on to the pelvic floor in just a minute, but before we do, vaginal estrogen is the gold standard, but it's not the only tool in the toolkit. Dr. Rahman, talk to us about DHEA and how it differs.
Yeah, vaginal DHEA is amazing for all of these symptoms. DHEA is a precursor to both estrogen and testosterone. And what we have to remember is we have estrogen and androgen receptors in the vagina, in the vulva, in the little slither of tissue at the opening of the vagina called the vestibule, right? If you think about a vestibule that you have to cross through to enter a room, you have to cross through the vestibule. I wish I had my model, I left it at home, to enter into the vagina. And the oh, okay, yeah, exactly. So the vestibule, it's a little slither of tissue. It's very, very concentrated in androgen receptors. It's actually embryologically the same type of tissue that the bladder comes from. And so when we think about, treating it optimally, a lot of people, and actually a recent study showed this, that a lot of people don't get 100% relief from a 10 milligram tablet that they put up in the upper part of their vagina, that they actually need treatment at the opening of the vagina, at the vulvar vestibule, specifically for that insertional pain with sex, and also some of the urinary symptoms. So vaginal DHEA or prosterone, or I guess I don't know if we can say the brand name, but it's Intrarosa. But it's
you can say it.
Okay, I can't. And so we use it. It's used every night. It's actually a little bit superior for sexual pain, but both of them are amazing for the treatment of the whole gender urinary syndrome. And the thing is, not everyone that has GSM has all the symptoms. And so some people might suffer more for the urinary, some people might suffer more from sexual pain, and then some people might have more vaginal dryness. And so depending on what you can access and what you can use and what you can afford, because that's one of the, I think, cost prohibitive. It's a little cost prohibitive for some people. It's gotten much better over the years. So in that respect, I think that at some point we're going to be able to, most people will be able to access vaginal DHEA, and that is, if I can get my patients to access it and get it, my go-to actually.
Dr. Gray Meltzer, I have recorded 270 podcast episodes, so I have learned a lot of surprising things over 5 years. But the thing that surprised me the most was that women in France get 10 paid pelvic floor sessions after childbirth. Now, I have had 3 kids, and I had never even heard of pelvic floor therapy until I became a podcaster. So help us become better patients. What does a pelvic floor therapist do? And what are the specific strategies that can help with things like painful sex, urinary leakage, and UTIs?
So it's pretty common when patients first hear of pelvic floor physical therapy that their first response is, there's physical therapy for that? My favorite term for what we do is pelvic health physical therapy, because it's certainly more than just the pelvic floor. We do have a lot of expert training in how to treat the muscles, the fascia, the nerve pathways of the pelvic floor, but we're also oftentimes looking at what's going on with the hips and lumbar spine, pelvic alignment, the feet, breath control, mental health, some of the lifestyle things that have been talked about. So ideally, we are a guide to all the different things happening physically in perimenopause and menopause. But I just want to give you a snapshot of what a pelvic health physical therapy session might look like, because oftentimes people are a little tentative and fearful coming in. So just like many doctors' visits, at first we take a detailed history. Oftentimes, just based on what people are telling us, we'll have some good guesses at what's going on, and we'll do a detailed description of anatomy, what might be happening, and what a physical exam is going to look like. Unlike when you go to a primary care doctor or OB-GYN, we don't use stirrups and speculum. Usually what a complete pelvic floor physical therapy exam looks like is we step out of the room, the patient undresses below the waist, lays on a bed covered in a sheet. They have something to drape themselves with, usually another sheet. We come back in, we glove up, and then we are looking at all the different bony structures on the outside of the pelvis, looking at the abdomen because of that fascial connection between abdomen and pelvic floor. And then if the patient's comfortable with an internal pelvic exam, we're using a finger either through the vagina or rectum to get more information about what's going on. So it's not one size fits all. Many people assume that we're just going to give a list of exercises and teach them how to do Kegels. But we need to be detectives first. So we need to know, is there density? Is there tightness? Is there muscle knots? Is there weakness? Is it more of a strength power thing? Or is it more of an endurance and fatigue issue going on? Or is it a motor control problem? Motor control you can think of as coordination. So for example, when we inhale, air is coming into our lungs, our breathing diaphragm should be expanding downwards, and our belly and pelvic floor should be able to soften and receive that pressure and expand. And on an exhale, everything should be able to recoil inward as our diaphragm rises and that air goes out. So if we find discoordination, that could be affecting everything from ability to relax and open the rectum and vagina and urethra for peeing, for pooping, as well as intercourse. So based on what we find in the exam, then we can lay out a very individualized plan to create more balance and good holistic function in the pelvic floor. And for many of our patients in perimenopause and menopause, that doesn't mean just one thing. Many people need a staged approach where first, if there is dryness and tightness, we might need to make sure that they're working with a doctor to get the estrogen therapy or just to get more counseling about their options to make those tissues more soft and pliable. And then we might help them both with manual therapy, meaning hands-on stretching and myofascial release, as well as learning to use tools like dilators and vibrators, which I think we're going to get more into a question about tools. We might teach them how to use tools at home to dilate, meaning stretch and soften those tissues, or to use tools like a wand to treat deep trigger points in the pelvic floor. But then once those tissues can move well, they might need a progressive strengthening program, as well as some functional training, how those muscles are actually going to work when they are working out, when they're sneezing, when they're coughing, and helping them differentiate between some of the pain and shortness and tightness that can create urinary frequency symptoms versus some of the weakness or lack of coordination that can play into stress urinary incontinence.
I will share in the spirit of what stays at the colonnade, what happens at the colonnade stays at the colonnade, that I did, once I figured out pelvic floor therapy existed, I did it, and it really helped with some urinary frequency issues that I was having. So 10 out of 10, recommend.
100%.
I want to hear from Dr. Men and Dr. Rahman. When do you send patients to a pelvic floor therapist? How do you see them sort of working hand in glove with what you offer as a clinician?
I mean, I have a pelvic floor therapist that I employ in my office, so almost every one of my patients sees a pelvic floor therapist because I treat a lot of sexual pain conditions, And I think, I always say that, you know, in this day and age, if you pay attention in the world, you're clenching, right? Like, otherwise you're just like not paying attention because the world is on fire. And, you know, if you're clenching your jaw and you're clenching, you have TMJ, you're clenching your pelvis, and you really can then contribute to that high tone pelvis that we're talking about in terms of, you know, rendering some sexual pain and weakness. And so, you know, every one of my patients, especially even my 20s and 30-year-old patients, have anxiety. They're clenching away, and I'm telling them, you know, we need to go see my pelvic floor therapist. And so, like, it's an essential part of everything I do.
And I'll just add, you know, just like I give a shout out to the women's health nurse practitioners out there who are meeting a need. I really feel that our pelvic floor therapists often, I find, are the ones who are identifying that, wow, this woman has GSM, and I see it from the cancer standpoint, that a lot of cancer survivors, not just breast, colon cancer, GYN cancers, other things, or women who are having other pelvic floor issues, are sent to the PTs for help, but nobody actually gave them vaginal hormones, and it's the PTs who are speaking up and advocating for these patients and helping direct them to accurate information. So that's so important. And what I also see is that when you have long-standing, untreated GSM, and I have seen this with women who have maybe been 4, 5, 10 plus years on aromatase inhibitors, ovarian function suppression, or they had colon cancer and they had radiation treatment, and literally nobody treated their GSM. So what happens is untreated GSM, not only is it decreasing tissue quality, but when they do have sexual intercourse, like as Tamina said, they'll tense up and their pelvis gets tight because of fear. Yeah. Your brain is going to protect you if it thinks you're in harm. So even in just a general perimenopausal and menopausal woman, they say, well, I don't have a low libido, I'm not interested in sex, because guess what? If sex is a little bit painful and your muscles clench up and then it's tight and then you're dry because your brain's sending a signal, you're not going to desire something that is painful. And so I see long-standing, and you can speak to this, of the muscular dysfunction that happens from untreated GSM, because it sends this this whole trigger. And this is why I always tell women, if you know these symptoms are happening or you're about to go through many years of estrogen deprivation, please be proactive so that you don't go down. You don't have to fight to get everything back. And if that does happen to you, we can all work together as medical specialists, and we can really, we've all seen incredible improvements when we use pelvic floor physical therapy and appropriate hormones.
Dr. Gray-Meltzer, let's build on that. So vaginal estrogen, DHEA, could help with pain, but pain sometimes still persists for women. What might be a reason pain is persisting, and what are some treatments?
So it can really be multifactorial. So first, let's start with the tightness piece. So just like the other doctors were mentioning, even if you have hormone therapy on board, if you have had tight contracted muscle and fascia and guarding out of fear for many years, and unfortunately for many people that I see, it's been many years, that is not going to automatically just completely dissolve with starting hormone therapy. It gets the ball rolling and preps the tissue. So in a normal state, muscle fibers should be sort of like fingers laying parallel to each other. When they contract, the fibers slide over each other. And then when they're asked to relax or stretch, they're smooth and parallel and slippery, and they can lengthen and slide past each other. But when tissues have been in a dry, low estrogen state for a long time, think of them more as tangled and twisted. So if there were knots in a rope, even if that rope still had a little bit of elasticity to it, if you don't untangle the knots, but you're pulling at either end of the rope, those knots are just gonna feel like sticking points. And oftentimes that's what people are feeling when they're trying to have something penetrate the vagina, whether it's a toy, a strap-on, or a penis. So one of the first rules of physical therapy, assuming that we do on exam find that tightness, is to gently start teaching people not only yoga type stretching and breathing techniques to relax and release but also doing some hands-on treatment. Just like any other area of the body, you wouldn't be surprised if there was muscle knots and trigger points that there would be hands-on treatment for it. Well, there is for the pelvic floor too. And that's something that a pelvic floor physical therapist or occupational therapist who has specialty training can help with, and something that we can teach people to do at home with fingers as well as tools. So then the second piece is that once muscles can move well and in a pain-free range, there's the strength piece. So rapid pelvic floor contractions can actually be part of orgasm for many people. So oftentimes, if a muscle's been frozen, it's also weak. And sometimes this sounds sort of paradoxical, because for some people, they think of short and tight as also like buff and strong in any muscle in the body. But there's a reason that these professional athletes are doing heavy strengthening, but then they also all have their trainers stretching and rolling stuff on them and using the massage guns. A muscle that can be soft and elastic can relax fully, but it can also contract through full range and can contract more efficiently and quickly, which is important for a full orgasm experience. So then oftentimes we're teaching a gradual progressive strengthening program. And the reason I'm emphasizing gradual and progressive is just like any other muscle in the body, we give it a strength grade. And if you can barely do a trace contraction laying down, what might be appropriate for you as a starting point might be different from somebody that can do a full range 10-second hold contraction laying on a table. That person then we're starting to test in standing. We're putting biofeedback on to see what's happening when they're squatting and lifting. So everybody starts at a different point. And then the third piece is sometimes what we call graded exposure. So just because you have the hormone therapy on board, just because your muscles are soft and flexible and now they're strong, and maybe now your physical therapist can insert a finger and do an intravaginal pelvic floor exam and you no longer have pain, if the last time you tried to have intercourse with penetration, it was very painful, everything you and your therapist have done together is not going to erase that memory, to your point. So that's where a lot of tools can be handy. So dilators are just basically silicone wands. A full set is oftentimes comes in 8 sizes, so these are just 2. And part of the point is to physically stretch tissue, but also to reintroduce in a very graded, gradual way, being in control of what's happening when something's entering the vagina. So often this is something that the person with female anatomy starts putting in on their own, gradually progressing the size, maybe going very slow, lots of lubrication, breathing through it. At first, maybe just putting it in, distracting, or doing a guided meditation for 10 minutes, and then eventually being able to tolerate moving it around. And then this can also be a tool to get a partner involved. You start giving up a little bit of control and learning to communicate about how fast something can be inserted, how fast something can be moved around before going to a penis. And then also just a word about vibration. Vibration has high quality evidence behind increasing blood flow, desensitizing nerves, toning muscles. So it absolutely should be something sort of like right along with the hormone therapy that's used routinely for muscle conditioning, either within the sexual experience or just really as like routine self-care and medical therapy.
Get those vibrators, ladies. Dr. Rahman, in a minute, we're going to transition into how we can both have better conversations around intimacy and pleasure with our partners, or maybe to think about it for ourselves in a sort of a solo experience. We want to be able to communicate better to our clinicians so that the people who help support our sexual wellness. But before we move into that last part of our conversation, I don't want to miss the chance to talk about testosterone. It came up earlier in an earlier panel, but I want to talk specifically now about the role that testosterone plays in our sexual wellness.
Yeah, 100%. Testosterone is the one indication that I think we have the most guidance in when it comes to hypoactive sexual desire disorder, which is you want to have sex, but you can't get there. And I always tell patients with any of the medications that we have for HSDD, which include 2 FDA-approved medicines that we can talk about later if you wanted, but the Addy and the Vyleesi, none of these meds are going to make you hot and horny for the person that you've been with for 20 years, right? Like, if I were to survey all of you guys and ask...
Boo!
I mean, just spontaneously, I guess I should say, right? Like, if we were to ask all of you why you have sex, and you've been in a long-term relationship, I'm sure very few or none will say because you're horny. It's usually a responsive thing. The reality is we understand that women in long-term relationships particularly have a responsive desire. Sometimes you have to be aroused. Sometimes, that's why the whole idea of like the man who's taking care of their kid and doing the dishes, they call that chore play because, women are really excited about seeing, the spouses do stuff for them. And so I think that's really important to set the stage for. And testosterone, when we talk about testosterone, it really is most studied or most indicated for hyperactive sexual desire disorder, but we have to understand that our brain is our biggest sexual organ, and we have what's called the sexual tipping point, which is what is it that's putting us into the let's go sort of like proactive mode versus the inhibitory mode, right? There are medications, because remember, sex is biopsychosocial. There's biology, there's psychology, and there's social issues that come up and why we want to have sex. And so libido is a mood that we have, right? And so what happens on our brain when we take testosterone, it can really improve our libido, improve our mood, improve our desire to have sex, and then it can also improve, arousal and orgasm, because our sexual function is really circular. It's not this linear thing that we used to think of when we think of the old Masters and Johnsons. And so testosterone is one of the things on that sexual tipping point that can really improve our sexual desire. Testosterone, we've got oxytocin, you have dopamine, you have norepinephrine, all of these things biologically that really help our brain to get us into an excitatory mode when it comes to sex. Versus like serotonin, right? Like antidepressants really kill a sex drive for so many people, and that's one of the reasons for it. And so I think it's really important to remember that. And so when I start people on testosterone, and there's for sure people that tell me when they start testosterone, you know what, I'm not sure my desire is there yet, but I'm thinking like this, or, I feel a little bit more energy. And our tricky part of testosterone is what we talked about, right? We don't have a standard government-approved testosterone. We have to kind of like come up with these formulations and how to, this standard dosing of how to talk to patients about it, a peanut M&M size portion into the back of your leg, whatever you tell your patient, right? But I think that, the fact is a lot of patients do have a very positive response from it. Doesn't come overnight. You still have to have other factors like that are contributing to your libido, like checked into. But testosterone is one of the things that we use in our toolbox for improvement of sexual function. And no doubt, I have patients who have other improvements, and they're like, "Don't take away my testosterone. My sex drive isn't back yet, but it's really making me like feel good, my mood, all the things." So I think there's definitely, and hopefully in the years coming, we're going to get more data to really suggest this. But it really is also setting up your patient for an understanding that, maybe instead of rejecting your significant other 10 times a month, you might only reject them 2 times a month, right? And so that's okay too, right? Like, it's really understanding what you can't tell a patient that they're just going to be like, because I have patients who tell me, well, my doctor wouldn't give it to me because they thought I'd want sex all the time, and I don't have time for that. That's not the case. Sorry to burst that bubble.
We're moving into the pleasure and intimacy portion of this conversation. Dr. Men, I went to college in Massachusetts. About an hour from here, I went to a Catholic college called Holy Cross. By the time I graduated from Holy Cross, I had spent 12 years in Catholic education. During those 12 years, I had about 5 minutes of education on reproductive health and 0 minutes of education on pleasure and intimacy. So as a starting point for this last part of our conversation, why is pleasure so essential, and how can women, particularly in midlife, reconnect with it?
Well, we value it in men.
Yeah.
So 50% of men will have some degree of erectile dysfunction by the age of 50, 60% at 60, 70% at 70, right? And we've got multiple FDA-approved options for that. We've got lots of options for them for testosterone because we value them achieving pleasure, right? We don't teach, yes, Catholic school, I get that, but it's across the board. We don't teach young women. We teach them about their periods. We teach them about how to get pregnant and how not to get pregnant and how to prevent STDs. And that was basically the extent of my training as an OBGYN in sex, basically how not to get pregnant and not to get infections. So I think it's really a bigger conversation that I hope that us as midlife women can actually teach our daughters and our young women that pleasure matters. Pleasure matters because sex is a normal biological function and it's something that you deserve. And it doesn't mean pleasure has to come in every traditional way that we've been ingrained to think. It doesn't always mean penetrative sex. It doesn't have to mean sex with a partner. But there's a lot of ways to define pleasure, and it doesn't always have to end with an orgasm. Oh, that's a lovely ending, right? But you know, it really is very sad, I think, that, you know, many women, even young women, are not taught that, you know, what they should be asking for pleasure. So your midlife, again, great time. If it wasn't, you didn't have good pleasure going through these past years, you know, your life, you're going to pause. It's a time of reflection, and you can actually have the best sex of your life at this menopause transition. So, you know, there's a lot of ways we can do that.
So thank you so much. That's a wonderful jumping off point for this. So, and it's a great segue into what I want to ask you, Dr. Gray-Meltzer. The world has really changed in terms of the tools that are available to us in terms of vibrators and sex toys. You know, when I grew up, they were something that was like wrapped in a brown bag, but now they're like, they're available everywhere. And they're increasingly seen as a very useful health tool. They can be a lot of fun. So walk us through the data behind sex tools and how might someone begin to incorporate them for solo pleasure, but also partnered pleasure.
So I feel like we haven't talked enough about the clitoris. We've been talking a lot about the vagina and vaginal opening, but many of the patients that I see, they're not aware that it's actually quite common for women at any stage of life not to feel that much pleasure or achieve orgasm through vaginal penetration. So it's important to realize that even though we talk a lot about vulvovaginal health, that perimenopause and menopause absolutely affects the clitoris, and obviously that plays a huge role in pleasure. So let's just do a little follow-up anatomy review here. So unfortunately, I did not travel today with my 3D printed clitoris. We were having a little discussion about this last night.
We all have moms.
My husband does have a 3D printer, but I could not convince him late last night to like quickly 3D print me another one. So this is a little small, but I consider this just a general takeaway. So it's okay if you can't see that this is yellow, but basically at the top or anterior end of the pelvic floor here at the top of this muscular triangle.
There you go.
That's what happens if you don't have enough vaginal estrogen.
That's the GSM.
Extreme endpoint.
The pelvic organs are falling.
So there is a little muscular and fascial hood here called the clitoral hood. And on this model, it looks just like this tiny little yellow dot or bulb. But it is much more extensive than this. So maybe this is a little size exaggeration, but basically right behind the pubic bone, if you imagine that my middle finger, the tip of it would be that little yellow bulb on the model, but there's this actually extensive bulb extending back behind the pubic bone, and then my fingers would be like a network of nerves spreading out throughout the pelvis. So we really want to make sure our patients understand the role of the clitoris, different areas to stimulate, because sometimes if they're just told about vibration, they might assume that they should be feeling pleasure just by inserting a vibrator into the vaginal opening. So this, for example, is a pelvic wand that can be used intravaginally or intrarectally to help patients treat trigger points, which are like hypersensitive muscle knots. But there's also a little power button you click on, and it has different vibration modes. So the nice thing about these sort of multi-purpose tools is patients can also be instructed to place it in different areas around the clitoris and labia, be instructed in different movements. OMG Yes is a great web-based resource for learning different ways for women to pleasure themselves and touch and manipulate the clitoris. There's also vibration tools, though, that have multiple prongs that unfortunately don't have a show and tell model, but they'll basically have a prong that goes into the vagina and then another prong that comes on top of the clitoris. I think it's important, though, to realize that you can use vibration in many different ways and present it in many different ways. I think some people are going to be scared off by viewing it as a sex tool or being told to go to a sex toy shop online or in person. So for some of our patients, they're going to be more receptive if we really do talk about it as a medical tool to condition muscles to increase blood flow, whether it's to help prevent UTIs or to help decrease symptoms of pelvic organ prolapse, or for other people, they're going to be rah-rah about viewing it as a sex toy, and we should give them a green light. I believe some study protocols look at using vibrators, I want to say 10 minutes 3 times a week or something in that ballpark if we're talking about regular use to help recondition muscles. So again, I think it's important to emphasize that it could be used for in the moment self-pleasure, either alone or with a partner, but there are pretty robust studies also looking at regular use of vibration as a conditioning tool as part of like a range of therapeutic exercises for the pelvic floor.
Thank you. In a minute, we're going to open the floor to questions. We know you have them. We really want to hear from you. You're going to line up there, and we're going to try to do as many of them as possible. But I do want to close with one last question for Dr. Men, and it's a big, complicated question, but I'm going to ask for a short answer if you could give it, since we want to open the floor. Communication is lubrication, right? Communicating your needs to your partner in heteronormative relationships is can be challenging sometimes. I'd love to hear like your quick piece of advice on that. And then for every woman in this room, when they want to talk to their doctor about the fact that their sexual wellness is struggling, what is one piece of advice that you would give to open that conversation?
So for partner talk and communication, you're 100% right. And I see a lot of patients who are presenting to me already with a lot of dysfunction, and they feel broken. They're teary-eyed when they talk about it. For instance, I just had a patient who was 35 years old, breast cancer patient, hasn't had sex for a year, afraid to even go to her GYN exam because it hurts and it bleeds when she has a speculum exam. And she has a loving husband, but the communication breakdown in this has been hard. And so one tip I say is, if you can't communicate it with words, it's okay to write them an email. I mean, I know it sounds cool, or and just say, here's why I am having these issues, right? Sometimes like when the partner knows like, oh, there's a biological reason. I'm not allergic to you. I don't hate you. I have pain and I haven't gotten medical care for my GSM. And when you're like, hey, I found out that there's things I can do. I'm going to work for this. It's a great opportunity to then also say, I care about this part of the relationship, so I'm doing these things, which kind of stink, right? I got to go to PT, I got to use these vaginal hormones. What can you do? You could also be like, and then from your end, these two things, I'm doing this for our sex life. Can you do these things? And I think most partners who are worth having will respect that. And if they don't, well, that's an answer for you as well. So I think that's important. And then with your doctors, we didn't get good sex training, right, for sexual dysfunction management. So a lot of doctors are scared and they don't know what to do, so they don't bring it up. So you can, unfortunately, it falls on the patient. You can make it easier for them. A couple list of symptoms, put it in the portal, let them know you want to address this, and you could say, I know maybe you're not an expert in this, but we just talk about XYZ, and can I get a referral? ISHWISH, International Society for the Study of Women's Sexual Health, a great resource for you to get some talking points. And there are doctors who can help you. And even if you start small and build. So.
Fantastic advice. And letstalkmenopause.org has a library of resources. Many are on this topic as well. I would urge you to check them out because you're going to learn a lot. So we're going to open the floor to questions right now. We want to try to get through as many of them as possible. So if you have one, please line up at the mic. In the spirit, again, of what happens at Let's Talk Menopause stays at Let's Talk Menopause. Feel free to be vulnerable. Feel free to take advantage of these wonderful doctors here and ask your questions.
One from online, which is, what are the benefits of adding localized DHEA if the patient is already using the E-string for GSM? So maybe that, but maybe expanding on how do we layer kind of layer treatments on top of one another.
And
Dr. Rahman, can you take this one?
Sure. And a lot of times, if someone is doing E-string, which is that ring that you use for 3 months, we'll sometimes even compound an estradiol testosterone cream to apply to the opening of the vagina, that vulvar vestibule, which is the source of most pain. If you're using an estrogen, the way the vaginal DHEA works, it's a nightly suppository, and it kind of dribbles into the vestibule over time, and that's how it prevents painful sex, because the E-string should provide a lot of the vaginal support that you need, but that when it comes to the urinary symptoms and the sexual pain, sometimes you do need that local estradiol testosterone combination, and so many of us will use a trusted compounding pharmacy and compound a cream that you can just directly apply to there.
Thank you. Next question.
So my question is around pelvic floor health in the context of strength training, because we all know we should be doing it. It's been mentioned here. And yet we know that pelvic floor health issues are becoming more prevalent in this transition. So is there any guidance you'd recommend, not for the woman who knows that she has issues and is getting care from a pelvic floor PT, because then if she were to start strength training for the first time, she would have someone to guide her. But in general, you know that this is a vulnerable area and you know you need to start strength training. Maybe you've never done it before. Any guidance around that?
First, I think it's very important to understand actually what a pelvic floor contraction feels like. I see a lot of people that say like, oh, I've been doing pelvic floor strengthening, I've been doing crunches, or I've been doing Pilates, or I've been doing squats. Your pelvic floor may be appropriately co-firing with other muscles when you do those things, but it might not. So just for anybody that doesn't know, a pelvic floor contraction should feel like a combination of holding in gas, vacuuming a marble up into the vagina, and stopping a stream of urine. It should feel like a squeeze and lift away from that chair that you're sitting on, almost like your perineum area is going up a little elevator, and then you should feel like you can reverse that and let out a stream of urine, drop the marble out of the vagina, relax your anus down and out. So oftentimes if people go online and look up how to do a Kegel, they'll maybe learn how to do a pelvic floor contraction, but maybe not then learn how to integrate that into other exercise. So one, it's important to know how to do an isolated pelvic floor contraction, so you actually know what your true pelvic floor feels like. But then it's important to know how the pelvic floor should work, not just in isolation, but in coordination with other muscles. So sometimes we call the pelvic floor the floor of the core. So a couple principles that sort of everybody could take away and remember are to exhale and contract your pelvic floor on the effort. So if, for example, you were going down into a squat, that would be your time to take an inhale. Let that belly hang out a little bit. Don't overwork your pelvic floor. You're moving with gravity. But when you're coming up from the squat, that would be a good time to exhale, squeeze and lift your pelvic floor to support those organs as you let the leg muscles do the work of actually moving you. So if you can practice doing that exhale, contract your pelvic floor on the effort of an exercise, that's going to go a long way. Obviously, the more guidance you have to make sure you're doing it right, the better, but that's something people could start practicing right away. But just as important is then making sure you're pausing and relaxing, because we do see a lot of people that got very enthusiastic about an exercise program, but then went through an entire Pilates class maximally clenching their pelvic floor. So if you're resting, your butt should be relaxing, your belly should hang out, and your pelvic floor should hang out too.
Great.
Everyone's got their homework assignment for tonight. You're going to report back. Dr. Erickson, a question.
One of the clinical things that comes up for me a lot, and maybe women in this room might benefit from hearing this, but spironolactone is used a lot as our relative androgen level compared to our dropping estrogen can shift, and women start to develop issues with low libido or vaginal dryness, and the importance of androgen receptors in this area is now something I'm acutely aware of. And how do we balance when we have the benefit for hair loss and for hormonal acne that these androgen receptor blockers like spironolactone can help? How can we balance that in these patients who are also simultaneously struggling with genitourinary syndrome of menopause and with libido and energy levels?
Give them the hormones back. Right? So like local vaginal, so it's such a great point because a lot of perimenopausal women are given birth control pills for symptoms, contraception, bleeding. Birth control pills can be an excellent option for perimenopausal women, but we have to be honest with them. One of the reasons why it helps their hormonal acne that they may have kick up again in perimenopause is it is lowering circulating levels of testosterone. But they can have their cake and eat it too. They can have the oral contraceptive pill if that is helping them with their symptoms and they need that. And we can give them local vaginal hormones. And even Dr. Rahman alluded to, even in our younger women who are on long-term birth control pills for contraception or for acne, 20-year-olds, teens, you know, they have never learned what sex is without being on a pill. They don't realize that they can have some dryness and atrophy and lower libido. And Samina, I'll let you answer about this idea of women who are on these more androgen suppressing medications. How do you find systemic testosterone work in those situations? She's more of an expert there, so I'll let her take that.
I think that's the hard part, right? Because you know, you are simultaneously reducing their levels at the same time as giving them some testosterone back. I think what we don't know is each tissue responds to testosterone at the receptor level so differently that if I'm suppressing your testosterone and you just happen to have a receptor defect at the vestibule, you're in those less than 10% of women that get that painful sex or that genital urinary syndrome of use of oral contraceptives. We don't have a name for it yet. But you know, and so sometimes it's like we have to give them the estrogen testosterone back and try to get them off the pill, right? But for some women, they'd rather have acne because they're not going to want to have sex if they have acne. You know, like their body image is just so related to that. And so I think it is patient dependent. If we can find an alternative to spironolactone, if we can find, you know, a lot of patients go on Accutane, you could probably speak better to that to me, but I have a lot of patients who will come off of the spironolactone because they want to be on the testosterone, and they go on Accutane with their dermatologist. And so I think that is something to consider because I think that's a hard balance, and we don't always know how they're going to respond until they go on it. If they have that benefit, or they might not be getting a maximum, or I might push the envelope with those spironolactone patients a little bit and say, I tolerate your level a little bit higher because that's when you get the benefit.
We have time for 2 more questions. There's one in the back, and Alessandra, if there's another question that came in from online, we'd love to take that.
I was curious, for testosterone, is it based on your clinical symptoms, or do you check a testosterone level and then guide patients based on that?
And we have excellent guidelines from ISHWISH and the Menopause Society as well on HSDD with the use of testosterone. We just don't have excellent FDA-approved drugs for women. But what we do know is, you know, we do always check a baseline because we want to know where we're starting from. We do go by symptoms as well. And the point of checking that baseline and the point of following up, you know, 6 weeks later and then 3 months later, 6 months later, what the timeline is to make sure that we're not really getting to super physiologic dosing, right? We need to make sure we're honest with patients about the potential side effects of using testosterone, and we think if we keep them in that physiologic range, which depending on your lab might be 20 to 50 or 30 to 70 depending on your lab, of that premenopausal patient, right? And so we want to be honest with patients and say, you can get acne, you can get facial hair, you might get some hair loss. For the most part, I think if you keep them in physiologic range, you hopefully won't get that voice change or that clitoral enlargement. But there are patients who have been in physiologic range that have gotten that. So, like if your voice, if your career is dependent on your voice and you don't want that deepening to happen, you have to. I'm very honest with my patients and telling them that because we don't think that one area is necessarily reversible. But watching those levels and monitoring them to see if we're in premenopausal levels, we don't want patients to get super physiologic, and so that's how we do it in that respect. And so we tell them, take one of the male FDA-approved testosterones, use 1/10 of the dose daily, and then we check your levels based on that.
Okay, and then so just to confirm, for women, physiological normal is 20 to 70?
It kind of depends on your lab in terms of what it is, but I think some labs it's like 30 to 70, some it's like 20 to 50, and it'll come up red for some people, but it kind of depends if the patient is doing well at 60 and they're telling me they don't have great, they don't have any adverse side effects, then I'm okay with their lab looking red on paper, because they're not having any adverse side effects.
And remember, all labs consider like the lowest level to be normal.
Yes.
So a testosterone level will come back as 1 or 2, and they're like, oh, it's normal. But it probably is not normal for you. that's what it is. But like, I think we do have to listen to our patients. So we're not treating to a level, and we don't have a lower, like if your testosterone level comes back at 30, it doesn't mean you can't start testosterone. We're just using it as a baseline to see, are you absorbing, how much goes up? So yeah, it's really a clinical.
All right, one last question from Alessandra from our virtual streaming audience.
Sure. So I will ask this in kind of two related questions. But the first one is, can my 83-year-old mother use vaginal estrogen?
Yes.
Yes. Okay. Great. But she has bladder cancer. So maybe can we talk a little bit about, especially if we have cancer, more localized cancers?
So bladder cancer is not a contraindication, and the only cancer that we are very, very careful, very particularly careful, there's some very rare sarcomas. Now, in the cancer world of estrogen receptor positive breast cancer, there's a lot of misinformation and a lot of lack of understanding that local FDA-approved options are very safe. And so, but the reality is patients got to get a lot of mixed messages from their doctors. The good thing is American College of OBGYN, the Menopause Society, the NCCN, these are cancer guidelines, they have very clear guidelines. So if you're unsure, if you have someone out there who has cancer or you personally have cancer, look to the guidelines because they're up to date and accurate, but sometimes the clinician taking care of you may not have actually read them or feel comfortable with them. So my message is for 99.9% of patients, vaginal estrogen is safe, and we all agree that we know that we can start vaginal hormones even if it was years from you ever being on them, or if you have contraindications for systemic hormones, you could still take local. I really think one message, we should go back to our mothers and our older aunts and just bring this topic up because they're uncomfortable talking about it, and it's not just about sex, as you guys have all learned.
Yeah, that's a phenomenal point. Please join me in thanking this panel for this incredible session. Dr. Rahman, Dr. Men, and Dr. Lynn Gray-Meltzer.
Okay, everybody. What another incredible panel. So we are going to be closing today's really fabulous lineup with our fourth panel, Strong Bones, Strong Heart, Strong Body, Investing in Your Long-Term Health. We're going to talk about the 3 critical health pillars there and strategies that you can implement today to manage symptoms and support. All right, let's bring our panelists to the stage. First of all, Dr. Pierre Boutet is a board-certified orthopedic surgeon with over 25 years of experience, a physician at the Orthopedic and Sports Medicine Center in Great Barrington, Massachusetts, founder of a private practice in the Berkshires. Her areas of expertise include arthritis, sports injuries, fractures, osteoporosis, and menopausal symptoms. Come on up. Dr. Jane Morgan is a cardiologist and vice president of medical affairs at Hello Heart. Dr. Morgan works at the intersection of clinical care, digital health, and public education to reshape how cardiovascular risk in women is understood and addressed. And Dr. Raghu Kumar is an endocrinologist and associate professor of clinical medicine at Weill Cornell Medical College. Dr. Kumar has become a national leader on the topic of metabolism and women's health. Come on up. And again, we're going to have questions at the end, so make sure you get those ready for this incredible panel and discussion. So I think the first question I'm going to ask is to each one of you, we can go right down the line, is how are you working with your patients to understand menopause as a window of opportunity versus this window of dread that, a lot of people I know feel when they hear that word?
In terms of how I approach this question as an endocrinologist and a primary care doctor is I think of this period as an inflection point to stay ahead of cardiometabolic risk change. And for women in their 40s, 50s, I think about what their cardiovascular risk will look like in 5 years and 10 years. And although their lipid profile, their insulin levels and their blood sugar may look okay at one point in time, I look for small signals. I look for weight creep, belly fat increase. Are your pants fitting you? those small increases in A1C, like at every physical, like the 5.5 to the 5.6 to the 5.7. Like I don't wait until they have prediabetes to say something. So I use this transition point to think about it as a cardiometabolic inflection, and rather than having menopause be a cardiovascular event where you suddenly say, well, now your risk of cardiovascular disease or your risk of a heart attack is that of a man's. So I would say I start early with counseling on nutrition, fitness, and also I'm a proactive user of low doses of GLP-1s when we start seeing these metabolic changes.
Dr. Morgan, you and I were talking just before we jumped on the stage, and I said, oh, I'm going to my cardiologist appointment for the first time, and she goes, you're long overdue. But, you know, we're not supposed to wait till we have the problem. So how do you address this as a window of opportunity for patients?
And Tamsen, that's such a great point, because I rarely get to address this window of opportunity. You guys don't come and see me. And so you're probably wondering, what's a cardiologist even doing at a menopause conference? I'm glad you didn't ask, because I'm going to tell you the answer to that question. The reason you should be seeing me, and the reason that Tamsen is late, is because seeing
We've known each other a long time.
Right? Is because when we look at all of these symptoms of menopause and perimenopause, and we're not just talking hot flashes and night sweats, right? These are the ones that everybody, you know, talks about, and these vasomotor symptoms, but it's all these other 40, 50 symptoms that you don't think about: itchy ears and vertigo and nausea and painful sex. All of these things are actually biomarkers for increasing heart disease. So that's how you should think about painful sex. Say, oh, my risk of heart disease is increasing. Let me go see a cardiologist. We have to begin to connect these dots, because that's actually what happens. Because the reason you're having these symptoms is because your estrogen levels are decreasing. Estrogen protects the heart of women. It's an anti-inflammatory. Inflammation is what drives atherosclerosis, those plaques in our arteries. And it's also a direct cardioprotectant, the estrogen milieu in which our heart works. Our hearts are smaller than men. We are dependent on estrogen. So as that estrogen decreases, our hearts are working harder, right? Blood pressure is going up. Cholesterol is increasing. That's increasing the work of the heart. So all of these symptoms that you're having because your estrogen levels are dropping are indicators that it's time to come and see Dr. Morgan. You need to be seeing a cardiologist because you want to manage your heart, not just the symptoms.
And Dr. Batan, let's talk about this, because it really is not being reactive, it's being proactive.
So it's interesting, my patients don't come in to see me because of menopause. They come in because they've broken a bone, or they have hip bursitis, or they have joint pain, or their arthritis is getting worse, or they show up because all their joints hurt. And I have to do more than just give them a cortisone shot or put them on an anti-inflammatory medication. I have to look at the whole picture in order to treat the patient. Otherwise, it'll be unless I treat the underlying hormonal problem happening, they will be in my office every 3 weeks with recurrent pain or recurrent hip bursitis. I can't just send them away to physical therapy and say I'm done. I think as a good doctor, I have to know that every system is related. I mean, your brain is connected to your bones. Bones are very much alive, and joints are alive, and we have to keep them healthy, and part of that health is addressing the hormonal problem, which becomes quite critical over time in my field.
But I love the fact that we're sitting up here with all these different disciplines now, finally all part of this same conversation, and that's really what's so important. Dr. Kumar, let's dive, because I want to dive into each one of your specialties, but let's start with you in metabolic health. What is it and why is it so important right now to prioritize, especially in perimenopause and menopause?
So we can define metabolic health as the entire process that involves eating food to fuel our bodies, turning that fuel into energy, and how we burn that energy. That is one definition. I also think we can think of it as all of the things combined that contribute to our cardiovascular risk. I think what's changed about metabolic health, especially in perimenopause, happens to be the class of medicines that are GLP-1s. I do think that they have changed how we think about disease. And I don't think we expected this in the early days of this class of medicines when they really were just for diabetes and significant overweight or obesity. But it's the first time a class of medicines has probably made us think about preventative health in terms of pharmacology. We always thought of preventative health in terms of just lifestyle. And GLP-1s, especially using them for perimenopausal insulin resistance, menopausal weight gain, the inflammatory picture that comes up as estrogen declines has changed the way we think about preventative metabolic health during the perimenopause and menopause transition.
Especially because we see such a change in all these different numbers during this time. I mean, I never had cholesterol, all of a sudden I have cholesterol. Never even talked about my thyroid, now all of a sudden I'm talking about my thyroid. And then weight gain on top of that. Let's talk about what happens in our bodies to cause that weight gain during this time in life.
Sure. So as estrogen declines, our body composition changes. Prior to perimenopause and menopause, we primarily store fat in our thighs and our hips, and although some people don't like it, it is completely fine and healthy. As we go through the perimenopause transition and after menopause, we develop more belly fat, so we go more from pear-shaped to apple-shaped. The problem with increasing that type of belly fat is that increases cardiovascular risk. That increase in belly fat comes along with an increase in inflammatory fat. And we see what we call remodeling of cholesterol and LDL. Our cholesterol becomes different and more dangerous to us. Our blood vessels become less flexible as we increase that inflammatory belly fat. So not only does the body composition change with an increased abdominal fat, that increases our cardiovascular risk. And then by 10 years after menopause, the cardiovascular risk of a woman or the risk of having a heart attack is the same of a man's. Whereas before the transition, the risk of a woman having heart disease is much lower than that of a man's. So what is significant about that change in body fat distribution is what it means for your long-term cardiovascular health.
Let's talk a little bit about maybe some of the tools or frameworks to help us reframe our relationships with our bodies and our diet, because we get a lot, I mean, advice is coming from everywhere right now, right? Is there something that you talk to your patients about to just kind of reframe that understanding?
Yeah, I mean, I think we need to throw the BMI tool out the door. It just doesn't help us. And I think it particularly doesn't help us during perimenopause and menopause. I think the saying that strong is the new skinny is really true, but I think women need to start working on this very young, like 20s, 30s. We reach our, optimal muscle and bone mass in our late 20s. I think restricting food, these unhealthy fads can really set you up for, from a muscular and metabolic perspective, an unhealthy perimenopause and menopause. So I'd get rid of BMI. It doesn't tell us anything about how much fat, how much muscle, how healthy somebody is. So somebody could have normal body mass index and be metabolically unhealthy if they have a lot of belly fat. And somebody could have high BMI and be metabolically healthy if their primary body composition is muscle. So I would move away from body mass index. I would try to get DEXA scans on people. These are becoming easy to get. My office has a scanner that does it in 24 seconds. So I think we really want to think about muscle and the role of muscle as a longevity organ in perimenopausal women.
Dr. Morgan, heart disease is the #1 killer of women. Critical we understand this vital organ. Let's kind of just walk us through heart health and what happens to your heart during this transition in menopause.
As I listen to the other speakers, part of what happens in cardiology, and something to think about when you think about the heart, is that we have two different types of muscles in our body. We have smooth muscle and we have striated muscle. Striated muscle are the types of muscles we have in our large muscle groups, in our legs, in our arms, and in our backs. So this is where we can develop strength and we can build. You have the ability to change those muscles. All of the organs in the body are smooth muscle, except one, the heart. The heart is striated muscle. It's made out of the same fibers as your legs and your arms and your back. So when I talk with patients, I talk with them, when we talk about the benefits of movement, of staying in motion, even if you are not losing weight, even if you're not happy with your body, your heart, that other striated muscle, has gotten a workout, and it has the ability to change and adapt like the other visible striated muscles. So that's why we talk about movement is very beneficial to your body, because the heart feeds every other organ, every part of your body. That's how you're getting your oxygen, your nutrients, the blood supply, all of that is coming from the heart. So when we talk about longevity, we really talk about heart health. There is no longevity without the heart. The heart exercises even if you do not see the results externally in your body. You get internal results from that other striated muscle. So that's something I try to help people kind of connect the dots and understand how this organ is different from the other organs. It's more like your legs and your arms.
If we look at some of the different risks that we need to keep an eye on, whether it's blood pressure or it's cholesterol, and then also how heart attacks present differently in women than men, can you go over both of those?
So when you look at risk factors, I'm a big proponent of monitoring, knowing your numbers and monitoring them from home, so that as physicians, we're not informing you when you come in for your annual exam, you're informing us that your blood pressure started to rise 7 months ago. And we're not sort of having this aha moment and this new discussion in the office, because for every 10 millimeters of mercury that your systolic blood pressure rises, that top number, your risk of heart disease goes up by 20%. So during perimenopause, we can have a huge shift in our numbers. And that bottom number, the diastolic number, actually is very important for women, especially in cardiology, because it can be an indicator of heart failure, that you may be at risk, a very specific type of heart failure, microvascular disease, so smaller vessels that we have. Because we have these smaller vessels, our symptoms of heart disease are often different. We don't necessarily have the crushing chest pain and shortness of breath, and we get sweaty and we lose consciousness, and somebody calls 911 and we get a defibrillator, and there's a big save and everybody applauds. No, we might just feel tired. Like, who doesn't feel tired? You have kids, you've got a spouse, you've got a job, you've got parents. So we might mistake those. Fatigue could be easily attributed to other things. Nausea. You might be tired when you wake up in the morning. You've just been asleep and you wake up tired. That's a really big sign. But we're not taught those symptoms. So what do? We just drag ourselves through, right? That's the reason why the first heart attack of a woman is more often fatal than the first heart attack of a man. It's the reason why heart disease is the #1 killer of women. It's the reason why heart disease is the #1 in prevalence for women. It is not breast cancer. Breast cancer is number 7. If you add all the cancers together, heart disease is still #1. Now, I'm not proud of that. I would like to see heart disease drop. And I think they've done a great job with breast cancer. But the fact of the matter is, it's heart disease that's the #1 killer. So these are all the things that we would like to educate you on, because the average delay in a woman getting treatment for heart attack is 37 minutes. And if that doesn't sound like a long time, that's the difference between life and death. Minutes matter in heart disease. Not only a difference between life and death, at 10 minutes, it's a difference between whether or not you can survive with quality of life, whether you're going to come back to where you are or whether you will be different. So it's incredibly important for us to understand what our symptoms are.
One more quick question. Why is there such a delay for women?
Ooh. The health system, and when I say the health system, I mean men, has been designed such that we extrapolate everything that happens to a man and we apply it to everyone else. And it's not just a man, it's a white man. And then we just extrapolate it to everyone else. So we really only know with our data, what happens in this very narrow demographic. And I'll give you a great example of why this is very, very dangerous. Last year at the European Society of Cardiology meeting, I've gotten my years mixed up. This is 2026. This is 2025. It was 2025. So August of 2025. So it's been less than a year. It seems like 10 years. It's been less than a year. At that meeting, we were in Madrid. They did a great presentation on beta blockers. Beta blockers are a class of medications, tried and true. Everybody gives them. We've been giving them for 40 years. There's so much research on it, we don't even bother to research on them. We give them primarily to people who've had a heart attack to prevent a second heart attack. This is candy in a cardiologist's office. We just sprinkle everybody with beta blockers. Turns out that data shows, we just got this in 2025, that beta blockers actually kill women. And that women who are given beta blockers have a higher rate of death, have a higher rate of hospitalization, and have a higher rate of heart failure. So we surely have killed women with this data where we don't bother to get data on anybody else except this narrow demographic, and then we just say, well, what's good for them must be good for everybody. So that's really a great example.
I had to ask you that because, you know, Dr. Morgan came on my podcast and it was the top rated, you know, of downloads of just information about the heart that I just had no idea. So I had to throw that one in there because I think it's really important. Okay, let's talk about our bodies, our health, our bones, and what is going on with our bones as we age and what role do hormones play?
Well, to set the record straight, bones are not inert. It's a very active part of the body. For example, the radius, your forearm bone, it's completely different cells than it was 7 years ago. This is a whole new bone. So we continuously make bone and take away bone. That rate changes according to what our hormones do. And it accelerates according to our metabolism and what's going on with our heart disease, with general inflammation, with our diet, with our lack of exercise. All those things impact. And all those conditions are all strongly affected by hormones. Estrogen, like you said, is a really potent anti-inflammatory. And as soon as you lose that protection, you start losing bone. And we start losing more bone in those first 10 years after menopause. So at first you start building bones, you build and build and build till you're about 27, 28 years old. And then you gradually stay rather steady but lose at a okay pace. But then all of a sudden, once you start losing your estrogen, you start losing bones faster. And that's when we have to catch women. Sadly, as an orthopedic surgeon, I catch them after that. They come in, they've already had a wrist fracture. Now, there are several fractures that are typical of an osteoporotic fracture. I wish, you know, it's like a wrist fracture. And really, it's a precursor to a hip fracture. How many women in this room have had a wrist fracture? There's a few hands, but not a lot, but there's a few. But we need to catch them in perimenopause. Because I've been doing this a long time, and I do use hormones in my armamentarium of medication or treatment for osteopenia and osteoporosis, I am getting more and more younger women showing up, but not enough. But I live in an area where I'm in the rural Berkshires, so we're definitely underserved in regards to menopausal treatment. I wish there were more of you where we are.
All right, we're going to talk about joint pain now in menopause. Frozen shoulder. Who's had frozen shoulder? Who's heard of frozen shoulder? All right, let's talk about it. What causes frozen shoulder?
Well, estrogen doesn't only affect, it affects the collagen. And frozen shoulder is essentially a problem of the collagen. Bone is made of collagen, but so is the soft tissues around the shoulder and the hips and other joints. But frozen shoulders are especially sensitive to a drop in hormones. But there's also a really high incidence of hypothyroidism and a subclinical hypothyroidism with frozen shoulder. And the most underdiagnosed condition in menopausal women is hypothyroidism. And we tell older women, oh, it's okay, you're tired, that's normal. It is not normal. And if your levels are borderline, I mean, I should not treat a frozen shoulder without addressing the metabolic issues and the thyroid issues. I can't just do a cortisone injection of the shoulder and send them to physical therapy. That's just not fair.
For women who have a family history of osteoporosis, are they doomed to weak bones? Because I think we're hearing more about bone health than we've ever heard before.
I don't think so. I really don't. We used to say that there was a 70% genetic, but I don't. I think it's such a multifactorial condition that has to do with our diet. Problem is, it's not our diet at 50, it's our diet at 20. Right. It's our diet and it's our lack of exercise at 15, 20, 25. So, yeah, maybe your parents didn't exercise, so you don't exercise. Sure. I really don't think there's just, we never found a gene that causes osteoporosis. Right. It's more of a metabolic condition. Osteoporosis is an inflammatory disease. And the inflammation doesn't just start at menopause. It starts earlier, and there's so many insults, and, in regards to food, environment, toxins that cause inflammation from the start. And we can't separate the bones from the rest of the body.
All right, let's go back to, we're going to go to treatments now, but let's start with metabolic health treatments. When we talk about lifestyle modifications and then medications, can you go into that a little bit?
Yeah, so the foundational platform of the changes in terms of treatment will still be behavioral. So the strength training, reducing sugar, increasing protein and fiber. But I do think we should have a pretty low threshold to introduce medicine if somebody is doing everything they are willing to do and everything they can realistically do, considering all of the things women of this age group are managing. We can't spend all of our time eating protein and lifting weights. And so if we're seeing the numbers still go the wrong way, or someone's really not feeling like they are in their body for them or the healthiest version of their body, minus body dysmorphia and cases of things like that, I think we can introduce things like metformin and small doses of GLP-1s, and we may need to use statins in women as their metabolic profile changes. And I think it's become more acceptable to offer GLP-1s to women who are normal weight, not overweight, but are starting to show this inflammatory picture of feeling puffy. They feel like they don't have a waist anymore. And you'll see within weeks for some women, again, not everyone should be on these, but when it works, that they'll say that this is not about my weight at all, but I feel better in my joints. They can't get their rings on for months or years, and suddenly their rings fit again. And this is all that relationship of estrogen and inflammation.
Let's talk about heart health options and treatments. 3 lifestyle modifications that women can do to start improving heart health right now. Dr. Morgan.
So a couple of things. I like vitamin D supplementation. And I think oftentimes we don't think about vitamin D for the heart, but it actually is a great fuel for the heart. And it's something that you can easily check to see what your levels are. As you're going through perimenopause, a lot of times our vitamin D levels decrease, but sometimes they don't. And you may be fooled, even your physician may be fooled into thinking, well, you're fine, you don't need supplementation. But the quality of the vitamin D changes. So your levels may be the same, but the effect is much less, and you do need supplementation. The other thing with vitamin D is when you're taking it, make sure you're taking magnesium with it, because magnesium is required to activate the vitamin D and drive it into the cells. So vitamin D goes along with magnesium. The other thing that I would say is that we can't get outside and just get some sunlight, right? Remember we used to be outdoors? Sun actually is how we get vitamin D in our bodies naturally. And as we become more and more and more indoors, we are becoming increasingly vitamin D deficient. So think about also when you're outside, and this is probably anti-dermatology, but skip the sunblock sometimes and just get some vitamin D. Think about your heart. Like, I'm going to balance the heart and the skin. Let me see what I'm going to do today. And I actually do that. And then the thing that I will say also about darker skin, if you have darker skin, you have more melanin, and it decreases the aging process. The flip side of it, it also blocks vitamin D absorption. So you can increase your rate of heart disease. So you look good, but your heart is aging. So think about that as well. The darker your skin, the more you are blocking the UV light, and you are more likely to be vitamin D deficient as you go through perimenopause and may need to supplement even if you are outdoors a lot. And if you have darker skin and wearing sunblock, then don't even bother to check. Just go get some vitamin D. You know that you're going to be deficient. So I would say that's probably my biggest one. The other thing might be surprising. I want you to go to the dentist and take care of your teeth. Mm-hmm. That's a big risk factor for heart disease. Jaw pain as well can be a symptom of a heart attack. If you have jaw pain, I want you to stop going to the dentist first. Go to the emergency room. Get ruled out for a heart attack. And then if you don't have a heart attack, you can go see the dentist and see what's going on. But jaw pain is more common in women because of referred pain from our smaller vessels in our hearts. So I would say those are probably the top two. And then blood pressure is the number one driver of heart disease. Blood pressure is increasing. Our arteries are becoming stiffer. They're less compliant, meaning they're less flexible. They become more rigid. The heart is pumping against a greater pressure. Know your numbers. If you are prescribed medication, please take it. I have so many women who come up to me to say, I don't take any medications and I'm 55 years old. Listen, that doesn't mean that you shouldn't be. Make certain that if you're prescribed medications, you take them and don't have a badge of honor of I don't take any medications because it makes you feel young. Your body is going to know the difference. Take the medication so you can actually be young and not just feel young psychologically. So make certain. So those are probably my top three.
And then let's talk about, I know there's not a too late time, but for menopausal hormone therapy to be preventative for cardiac, is there a time where it's more beneficial versus not as beneficial?
Yeah, this is such a controversial area. I'm probably going to say something controversial, but here's what I will say. What do we talk about? We talk about this window of opportunity, right? Where if you're going to take hormone therapy, it has to be within 10 years of menopause. So I would say that's kind of going out the door. It is individual precision therapy. Have a conversation with your physician or whoever your menopause specialist is. All the way up, women in their 70s. What is your risk? Do you have cardiovascular risk? Have you had a calcium score? Have you had a clearly? What is your family history? Let's take a look at that. That answer is not an absolute no. Now, the reason it's not an absolute yes is because we don't have the data to clearly demonstrate that there will be cardiovascular benefit in taking it beyond that window. What we do know is you can get some reversal of some of those symptoms of heart disease, the hypertension, the cholesterol, the weight gain, that type of thing. So it's an individual discussion, but I personally do not think that is an absolute no.
Thank you. All right, let's go to bone health and lifestyle modifications for women and what we can do to improve bone health.
Well, it has to start early. My number one thing is diet. And you're not going to like this. I don't say low alcohol. I say no alcohol. That's a big one. It's inflammatory. And patients come in. You know what I had is during COVID, everybody was stuck inside. They would get a bottle of wine and share it between two people. My patients, the increase in the number of women that came in with joint pains was spectacular. I actually noticed the difference. And so diet is a big one, and I wish we would stop encouraging young people to drink those crazy sugar caffeine cans. That's not food. It should be sold at wine stores. You should sign your life away when you buy one of those. So diet is a big one. Exercise. But I know we talked about walking. I think walking is really good. It's really good for your heart. But you need to do more than just walking. You need to do squats. You need to do stairs. You need to do strengthening exercise for your lower extremities and balance. Because in order to break a bone, you have to have two problems. One of them is usually your bones are a little bit thinner than they should be, but you also have to fall. There's a lot of people who don't have a great bone density test, but they never have a fracture. There's a couple of reasons for that, but one of the big reasons is strong. They're balanced. They exercise. So that's the second. And third, you talked about vitamin D. One of the top things, for when people present with osteoporosis or low bone mass, it'll be, smoking, alcohol, diabetes, and the fourth one is probably chronically low vitamin D. Vitamin D, long-standing, 100% of the people have osteoporosis, but people who have GI issues, they don't absorb vitamin D like they should, because we also absorb some vitamin D through the gut. They don't absorb other nutrients also, but any kind of Crohn's disease, IBS, all those conditions, most of those people have low bone mass. So those are things that are really important. And, vitamin D with K for me. What K does is pulls the calcium out of the blood and it pulls it closer into the bone. So for me, vitamin D with K, if you don't have any negatives. There's some people that feel that if you're on a blood thinner, you should not be on vitamin K, or if you've had a blood clot, you should not be on vitamin K. So I always ask the patients that. Magnesium is another important one. Calcium, again, through your diet.
If you're going to say supplements, those would be the three, though, that we're talking about, right? Vitamin D, K2, magnesium, and calcium for the three. How do you feel about weighted vests when it comes to bone health? I know that I'm in Central Park on the weekends, and everyone's got one. Now they've got like a thing where they're sipping water in it at the same time. Might have protein in it. I don't know. There's a lot going on. I feel very intimidated these days.
It's very trendy, like collagen and a whole bunch of other things. So I think if you're 20, 30 years old and you have a strong back, go for it. But I don't. Most of my patients, by the time they're 50 or 60 years old, have experienced back pain, and it puts a big load on your back. I'd rather see you do some squats or some stairs without straining your lower back.
And then I know we mentioned GLP-1s and hormone therapy, but that's something also part of bone health that you're seeing or prescribing?
I actually have been microdosing GLP-1s for inflammatory joint pains. There's so many times, if you don't have any positive markers, if you don't have a rheumatoid arthritis marker, they tell you, oh, let's put you on an antidepressant. But osteoarthritis actually is inflammatory most of the time. And there's such a great response. It is better than all the NSAIDs.
Okay.
Yeah, can I just say something about bone health and GLP-1s? A lot of people are talking about bone loss on GLP-1s, saying that GLP-1s eat your bones or lead you to lose bone mineral density. If you actually look on a cellular level, there are GLP-1 receptors on osteoblasts or bone building cells, and they suppress osteoclasts or bone breakdown cells. So technically, in a petri dish, GLP-1s have the ability to build bone. The reason people are losing bone mineral density is poor nutrition and weight loss with no resistance training. There are studies that show that if you take GLP-1s, lose body fat, maintain muscle, you don't lose bone. So just to clarify that.
And I want to clarify one other thing. That's a really good point. You actually can build bone. You reduce the inflammation. It really does build bone, but GLP-1s do. But also, the amount of muscle mass, everybody was worried about muscle mass with these GLP-1s. You do lose some. They say 12%, but the new studies say maybe 12% bone loss, muscle mass. But proportionally, you lose more fat. And I don't think that's a significant issue if you do any kind of exercise.
Thank you. I'm going to do a quick rapid fire, and then we have 5 minutes, and then we're going to go to questions. So I'll do it, to each one of you, based on how it impacts each one of your areas. So let's talk about family history and how it impacts your area of expertise.
Hugely impacts it with metabolic health. If there is a first-degree relative with type 2 diabetes, or somebody that even has pre-diabetes, I would say that these are people I am concerned about, even gestational diabetes, any red flags with blood sugar.
Okay. Dr. Morgan?
I would say family history is important, but 80% of heart disease is preventive. It's not genetic.
Wow.
And so I really try to emphasize that behavior is scalable, and you can change the trajectory. And even if you have a genetic component to your disease, you can impact how it's expressed. So you can make some choices. You may not be able to prevent it. You can delay it. You can impact the severity of it, the expression. But for heart disease, I don't want you to feel that there's nothing you can do. 80% of heart disease is all preventable. So just remember that. You have the power to do something and to do something about it.
I think that's encouraging, because I think that a lot of people assume that that's the kind of the shrug, right? Of like, I can't because this happened to my mother or my father. Okay, how does family history affect your bones? I think we addressed it a little bit with osteoporosis. But
Right, and I really like the way that Dr. Morgan addressed this. I think it applies to orthopedics or to bone health also. There's so much that we can do, and it is a systemic medical condition, and the risk of low bone mass is associated with your diabetes. I mean, that's where the risk is, which eventually leads to osteoporosis, but the problem is not the bone issue, it's the medical issues.
if there are some main tests that each one of you recommend to your patients, what would it be for bone? Would that be the bone density test?
Yeah, it is. Bone density and measuring your vitamin D level are the two
Okay.
main things for me. The problem is, so many of my patients don't show up to the office until they're 60 years old for their baseline level. And a baseline level doesn't tell me enough. Are you still losing bone? Did you lose bone over the last 10 years? I need to have a baseline probably at 45 or 50, especially if you have any medical conditions. I have to treat somebody for bone health who has diabetes much earlier than another person.
Okay.
So if you have any other medical issues, get it earlier. If you're concerned about it, get your baseline level earlier.
Okay. Dr. Morgan, what test do you recommend?
I would say get an ECG or an EKG. This is something that women don't get as a part of our physical exam. Men get them, but we don't, because healthcare for women is all about reproduction, right? Because that's what healthcare, and when I say healthcare, I mean men. That's what healthcare focuses on. So we're just breasts and vaginas. But the fact of the matter is that heart disease is the #1 killer. So are you getting a mammogram or are you getting a pap smear? Get an EKG. I can't tell you how many women show up in the emergency room and we don't have ECGs on them. We're going through the electronic records. They're having cardiac symptoms. It would be lovely to have a baseline on you. We're going through electronic records. It's like mammogram, 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 pap smear, mammogram, pap smear. Not a single ECG. She's like 45 years old. That's insane. But that's how our healthcare system works. So ask for an EKG, and not only when you're healthy as a part of your physical exam, but if you are being dismissed and people are not listening to you in the urgent care or the emergency room and you're concerned about your heart and they aren't, ask for an EKG. Now you're speaking our language, speaking the language of the system. You just communicated something to us.
Thank you. Dr. Kumar.
I would say the body composition scan to look at the ratio of fat at the belly versus the thighs. It's called the AG ratio on the body composition, and probably a fasting insulin to assess for insulin resistance.
Wonderful. Thank you all so much. I know we're going to take questions next. We'll start with some online, if that's okay, and then whoever it's addressed to or whatever our expertise, just grab it.
So there was a question around how to prepare for a cardiologist visit and what that visit might look like when you get there.
So we actually try to publish, guidelines and questions, not because women aren't intelligent enough to sit down with their cardiologist, because oftentimes when anybody sees a doctor, you like forget your questions. And women especially, we can leave with more questions than we actually came in with. So, the way to prepare is think about why you're there, and let's just talk about menopause. If you're concerned about menopause and whether or not there should be some things you should do, ask specific questions. Should I have a home blood pressure monitor? Drive the conversation. Should I be testing other types of cholesterol? LP(a). So ask specific questions that will help drive the conversation.
Great. And then there was a question around GLP-1s and how long one is on them.
So the traditional teaching for GLP-1s for the people that they were actually studied in, so very high BMI or type 2 diabetes, people usually need to stay on GLP-1s in order to keep the diabetes away and keep a lot of weight off. This idea that everyone is going to be stuck on a GLP-1 forever is not true, especially when it started early and used preventatively. I have perimenopausal and menopausal women taking 1 dose a month in combination with lifestyle, or people cycling off, monitoring what they feel like is their inflammation and their own health. When they notice what they call food noise or weight creep or sugar cravings, they'll do another round. This idea that you're either on a GLP and healthy or off of it and obese, there's a whole world in between that is nuanced and personalized, like everyone else has said, in terms of treating patients. And everyone's maintenance plan can look different.
Actually, my question was exactly on GLP-1s. My understanding is that GLP-1s actually reduce your appetite, meaning that you don't eat. What if you just want to have body recomp? You don't want to eat less because you think you're eating okay, meaning that you're careful about your diet. Are there alternatives to GLP-1 that will help you, like in the figure that we had there, redistribute the fat back to the way it was when you were in your 20s?
So before we became comfortable with using GLP-1s like this, and not everyone is comfortable with this use of GLP-1s, we always used metformin. Metformin is an old school medicine. It's safe, it's cheap, it's plant derived, it's FDA approved starting age 10. It's the medicine we always used in our post breast cancer patients that gained or had redistribution of body fat. We used it in patients that got their ovaries removed and had abnormal weight gain. We've used it in medication-induced weight gain, people that gain weight from antidepressants, antipsychotics, anti-anxiety meds. So metformin is an option. The other is this concept of microdosing. I think that the word has become somewhat trendy, and it's been kind of co-opted from like recreational drug use culture, so it's not a great word for something medical. But the concept of microdosing a GLP, which is using less than an FDA-approved dose, or a dosing schedule that might be more infrequent, every other week, every 10 days, every 3 weeks, doesn't have to suppress your appetite so much, but can still do the body recomposition.
I think that there is a really important topic that affects 1 in 9 women that is left out of this conversation, and it's the metabolic condition lipedema, a condition I was diagnosed with at stage 3 when I had 20 liters of fat removed from my waist to my ankles, a circumferential body lift, and a thigh lift. In women with lipedema presents in puberty, pregnancy, and menopause, and it is not discussed. It's nowhere to be found anywhere, and most doctors I talk to glaze over when I say it and say, do you mean lymphedema? Dr. Iyer, by the way, it was the first person who leaned in other than my plastic surgeon when I started talking about it. So when will lipedema become part of this conversation? And by the way, women with lipedema are 4 times more likely to require a total knee replacement. And as you might recall from earlier, I've had 2 in 4 months.
Yeah, so I'm sorry that happened to you, and I agree with you that it is underdiagnosed and almost never in the differential diagnosis of somebody that shows up to their primary care doctor or endocrinologist complaining of either weight gain or painful limbs. For physicians that are interested in becoming board certified in obesity medicine, it is on the boards, but again, that is a very small number of doctors relative to the problem. And part of the issue, and this isn't a reason to dismiss it or not learn about it, is the lack of treatments. It sounds like you obviously have a great doctor who's in the room that noticed this. My handful of patients who've actually had this diagnosis have gone all over the country looking for treatment.
Yeah. And also, women with factor V Leiden experience menopause 3.1 years earlier than the average person, and no one talks about that either, and I also have that. Okay, thank you.
I'm just here
So I'm just going to make a comment just about factor V Leiden. So actually we do discuss factor V Leiden. It is very specific. We didn't have a question on it today, but I think it's a really good topic. And Dr. Corinne Min, who was on the panel before, also does a deep dive into factor V Leiden deficiency. So for people who don't know, it's a clotting disease. And so it's a big part of the discussion when we talk about hormone replacement therapy, especially for cardiology. We specifically talk about any of these genetic inherited clotting disorders like factor V Leiden. So we did not talk about it today, but I will say this, it's very nuanced and it's very specific, but it is on the table. It's not invisible in our world at all.
We have many, many studies in men in dermatology showing the connection between androgenetic alopecia, which is male pattern hair loss, and heart disease. And it can be an early, very visible sign for men that they need to get an EKG and have metabolic syndrome markers detected. We have 3 studies in women that show a link between female pattern hair loss, androgenetic alopecia, and heart disease. And I guess my question is, this is a multidisciplinary panel. How are we going to close these gaps in research between men and women? So women who have more silent presentations of heart disease, but may have some very visible signs that could be early markers and beacons that they need to get help. How do we close these gaps? And how do we also get doctors out of our specialty silos and collaborate in rooms like this?
And so thank you for that. So women, often we do not have silent disease. We are expressing it quite loudly. Just nobody's listening and nobody's interpreting, right? So we're not silent. The system, and I mean men, has a blind spot to what's happening. So think about when we have these vasomotor symptoms of hot flashes and night sweats, literally your body is shouting to the whole world, look at me, my risk of heart disease is increasing and no one is doing anything about it. I do a social media series called the Stairwell Chronicles. I usually post on Wednesdays. I sit on the stairs in my house. Those are my house, it's my stairs, it's my clothes. And the last few weeks, I have been on my stairs writing letters to different specialties, asking them to join and come out of their silos and begin to treat women with menopause. So this week I wrote to, I think radiologists. I think I wrote to radiologists this week. Last week I may have written to dentists. And so every week I'm writing to different specialties saying, guess what? Menopause is on your table too. So follow along, and you can listen to me write these letters as I just send the plea out, because it's right, we do need to come out of our silos. Mostly women do not see physicians because I'm menopausal. We actually are seeing physicians everywhere, and it's the physicians who need to say, I've got a perimenopausal or menopausal woman in front of me. Now, what do I need to do? And so this is, but just know we're all on the leading edge. So most of you who are here today, when you leave, you will have more information than your doctors. And that's just where we are right now in the continuum. So have some patience while we try to catch up.
Let me know how my colleagues in orthopedic surgery respond.
Right. I will write a letter to orthopedics next.
Thank you very much for all everyone is doing. So very quick question. Vitamin D, I heard with K2, but then magnesium. Magnesium is a bit like alphabet soup. Which one should we be taking with it?
Great question. So different ones do different things. So magnesium glycinate is generally the one that we use for vitamin D absorption. Now, there are different types depending, magnesium oxide can be more for constipation. So, there can be some nuances for different other issues that you may be managing. In general, magnesium glycinate is the formula. There are
agree.
other forms for very specific, nuanced, personalized, this is your personal history. But other than that, it's magnesium glycinate.
I'm a recovering kindergarten teacher, okay, educator, for 42 years. And I just left education. We're running parallel tracks in healthcare and education right now, sadly. And so the majority of educators are 40 to 50 years old right now. And they have to take leave in order to get the benefit of the wisdom that you all are sharing. So planting seeds and asking, do you have any guidance for how to get this information across the board to educators and also the souls who may not have access to rooms like this and to quality health care?
You know, it starts in kindergarten. I think that's where you got to start teaching menopause, right?
I
Where you got
know.
that, you got
For
that
real.
rapt audience, empty brains. It's time to just shove it in there. So
We don't have to shove it, just pull it out. It's already there, right? Seriously, thank you.
I want to say something. I wrote a book, How to Menopause. If
I
there
read it.
are,
It's awesome.
Thank you. But if there are educators or teachers or people that don't have access and need books or need some information, we're happy to donate. So just come see me afterwards, and we'll do
Thank
that.
you, that's super
Yeah.
generous.
Yeah,
We'll
of
do
course.
book studies.
Of course. Of course.
Thank you.
Do we have any other questions? Online, maybe?
We have a couple online. So, I am 60, went into menopause 7 years ago. I'm overweight, hip pain, cholesterol, sky high. So, symptom soup. My doctor is not helpful. Should I take a GLP? There's a lot of themes up here. I'm sorry to say that. Should I take a GLP-1, start hormones, or statins? I'll fill in that.
change doctors. Start there.
Yeah. But I guess where to get started on all of this when you've kind of got everything going on? Maybe how do you parse that?
I mean, this seems like a very fair scenario to ask for a GLP-1, and it's not about the weight at all. It is about the inflammation. It's about the fact that for somebody like this woman, by taking a GLP-1, she could reduce her risk of having a heart attack, stroke, or dying a cardiovascular death by 30%.
When should I get a bone DEXA scan? I know I'm teeing you guys up here a little bit.
The recommended, a DEXA scan or a bone density test?
I thought they meant bone density.
It said bone DEXA scan. So let's answer both.
Well, like we talked before, the recommendation is at the age of 50, but I recommend earlier if you've got any metabolic issues going on. Or if you've had a pathological fractures, and a lot of people don't know that they've had a pathological, I had a good fall. If it's a fracture through the metaphyses or wrist or the proximal tibia or a distal tibia, the specific fractures are very typical of low bone mass.
Well, there was a question around peptides for cardio and metabolic health.
I'm not so anti-peptide. I am intrigued by it. I agree that they obviously are not FDA approved. There's limited human data, but some of these peptides have an FDA approved version of them, and people may not realize that. So there are growth hormone stimulating peptides that are good for increasing muscle mass, reducing visceral fat. There's a version of this drug that was FDA approved for HIV lipodystrophy, so people with HIV and AIDS that have a change in body composition under the name Egrifta, the brand name. There is a peptide that, part of the thing with these peptides is they sound so crazy because of the names by which they go. There's one called SS31. It works on your mitochondria, that bodybuilders are taking it, they're talking about it. It has an FDA-approved version in a rare condition in pediatrics. So I think people are like, it's becoming politicized that the peptides are representing the current administration that is potentially irresponsible in other ways or whatever people believe. But these peptides probably could have a use. I think they live somewhere between supplements and pharmacology, but they have to be studied more.
Yeah, I agree with that. I'm not anti-peptides. I think it's another nuanced area as we try to learn more about them. And, I think it's very difficult for physicians to practice outside of FDA recommendations. and these peptides don't necessarily have FDA recommendations for the way that they are being used. And so it doesn't mean that we don't do things off label, because we do things off label. So I agree. I'm not anti-peptides. I think there is a use for them and there's a place for them. And again, we're back to sort of individualization and discussion.
We have one more question, then we're going to wrap.
So my PCP told me I needed to wait till I was 65 to have my first DEXA. So I did. And meanwhile, before I turned 65, I had bilateral hip replacements. So I came out with osteopenia in my spine, and then they tested my forearms, and those are osteoporosis. How much can you correlate what you find in your forearm with what might be in your hips?
You're right that we don't have as much data on the bone density tests of your wrist, and they always look so much worse than the rest of your body. But you still have to consider it. What's most important for you, since it's your first one at 65, I'm assuming you've gone through menopause at least 10 years ago, is to have your next bone density and compare if you're still losing bone and if you're stable. And you have to look at the whole picture. Mm-hmm. If you've broken any bones, if you've got diabetes, if you've got thyroid disease, if there's any other issues at play, if you've been on a statin or an antidepressant for a long time, you've got to look at the whole picture.
Thank you.
Thank you. I want to thank everybody for such great questions, and and to all of you for your expertise and constantly giving your time and supporting all of this. If there's one thing I could ask everyone to do before I bring John up here, is tell a person, tell one person, tell two people, tell three people, because that's the way we continue to get this message out there and continue to help that next generation. So thank you so much.
A few more minutes. I want to thank Tamsen and all the panelists. Let's give them one big round of applause. I also want to bring up the Let's Talk Menopause, part of the Let's Talk Menopause team. Samara Daly, can you come up with me? Up on stage. I'm going to get her up on stage. Hasn't happened. Samara is my friend, my business partner, and the LTM co-founder, and so none of this would be possible without you. So thank you to Samara, and I'll thank the LTM. Yeah. I want to thank the panelists. I think some people went back to their practices. Dr. Jane Morgan, Dr. Wen Shen, Dr. Corinne Men, Dr. Tara Iyer, Dr. Haydeen Jaffe, Dr. Lynn Gray Metzler, Dr. Robin Noble, Dr. Samina Rahman, Dr. Rika Kumar, and Dr. Pierre Boutin. They were really all amazing. Thank you so, so much. We also want to thank Katie Fogarty for moderating the GSM panel so beautifully. And of course to Tamsen, one more round of applause. Really amazing. We so appreciate you. None of this would be possible without our incredible sponsors that Samara so aptly gets for us. So we are deeply grateful for their support. That's the Cohen Foundation, Bayer, Astellas, and Not Your Mother's Menopause. And thank you to the dozens of partners who help with all the goodie bags, stuff that you guys got in there, and local outreach. And thank you to our board. We are a nonprofit organization. So we have a board, Katie Fogarty, Gabriela Espinoza, Dr. Robin Noble, who is also our chief medical advisor, and always when we need her, she's always there for us. Risa Aronson, April McKenzie, and our host, Tamsen Fadal, who's also on our board. And of course, thank you to the Colonnade Hotel for hosting us in this space today, and all the tech people who are with us to make this all happen. The LTM team, not only is just Samara and myself, want to thank Marie Capozzi. Marie, raise your hand. Stacy Geller, who is our creative director. Have anyone seen our graphics lately? They're pretty darn good, and does our social media. Alessandra Henderson, our senior program advisor, who really helped put this Menopausium together, as well as Ada Moses, who I've known for a very long time. Yep. So thank you, Ada and Alessandra. Kirsten Kluth, who does our podcast. She's a producer of our podcast. And to our newest member, Mia Humphreys. She is our new communications PR person. So let's give our Menopause team a round of applause for putting this together. Before you guys head out, there is a survey on Slido. Please fill that out. We listen to you. We take your suggestions. We want to know what Menopause Talks to do. We want to know what else, what next year should bring. So please, we read every single one of them. We'll send you that link in an email follow-up, and we'll send you some other things too. We also compiled a resource guide for you in Boston and other things. So I think that it's going to go out to you in an email with you, and it's also a QR code right there. And so we compiled a bunch of Boston resources as well as national resources as well for you. So thank you. We really hope that you enjoyed it, and we look forward to seeing you, and we'll tell you our next city we're in next year. We'll do it at the same time.